can cause their side effect. And to treat those adverse effects, again, newer medicines are given. So like that, one drug induces, pushing for the use of other drug. Like that, the things are moving. So this is called prescribing cascades. So again, it's very important point to look whether a lot of the effects which we are seeing, whether these are caused by the drugs themselves. Is there a way the source of the problems are drug? Then we can actually reduce the dose or change the drug, or in such a way that you don't have to add a second drug to manage the problem. Rather than you can do something with the original treatment. This is where prescribing cascades play an havoc on the health of elderly people. They will have like 15 drugs. You can see, I've personally seen the prescriptions of 20 medicines in a single prescriptions. Okay, so this definitely needs a careful look whether a prescribing cascade has happened. One particular problem has led to another drug which is causing a problem, which is further leading to further use. So this is another important area. Definitely, when there are more than like 10 medicines are there in any prescription in any elderly, there is a need to carefully look, is there a prescribing cascade? Okay. This slide, some of you might have seen, and it might be sounding familiar, but that's the truth many times. The top prescription is for your arthritis, but it may cause a heart attack. Yeah, when you start treating with the NSAIDs for the joint, the NSAIDs will have cardiac problem. That's what it means. Second prescription should prevent the heart attack. So to prevent that, we give another drug, something which is helping the heart, but that may lead to another problem, liver problem. And like that, this one drug causing a problem, and you treat with another drug, and that is causing a problem. And it's not a joke anymore. It's already happening in a lot of elderly patients, especially when they have like too many medicines. So we have to be really careful. And if a clinician or a pharmacist are able to spend time and do a very thorough review on the health and compliance and checking with each drug and their history, definitely there is a chance at least 30% of the medicines can be removed and their associated problems can be reduced. That's what we have to understand this whole prescribing cascade. Then another important concept is de-prescribing. So we talk about the polypharmacy. To handle that polypharmacy, another important issue is de-prescribing. Okay, so the clinician or the healthcare team decides to work with the patient to stop a medicine. Okay, and after very carefully considering the benefits and risks of stopping such medicines, after a proper review, that's just stopping of any medicine should not happen randomly. It should be after a review. Okay, and then maybe this prescribing can happen because the changing needs of some patient. For example, a patient had some kind of joint pain or some kind of pain, an analgesic drug has been prescribed, but now that pain has gone. So best thing is to stop that analgesic drug as soon as possible, rather than if we just let it go. The patient may not know that this drug is for the leg pain or whatever you are complaining some time back. Now what happens? Patient will keep continuing the analgesic medicine. That analgesic medicine may create a problem with another, say NSAIDs, may cause gastric problem or a renal problem. That's where we should have kind of review and see the altered scenario based on that situation. If the patient is no more complaining of the particular problem and the medicine is given, should be stopped, right? So that's why it's very important. Every now and then the review should happen. De-prescribing should happen. And in India, the other problem is like patient goes to Dr. A, Dr. B, and Dr. C, and each will give different set of medicines. They will not look into somebody else's prescription, or the patient will not tell, first of all, I'm already seeing a Dr. A. So what happens? A doctor will look at the complaints and start giving therapy. And the patient will have 3 different set of prescription. They may take all 3 medicines. In that, there may be, it's my personal experience also. My father got admitted for some complaints recently in one hospital. The patient, my father already taking some kind of anti, and for cholesterol medicines and all he's taking, anti-lipidemic drugs he's taking. And the new hospital, they've given another set of atorvastatin is that they've added rosuvastatin. And it's all different color, different medicine. He was almost about to take both this medicine. I did not travel to meet him, but I could get the prescriptions, scanned and sent to me, and I gone through that and identified, removed the duplicate. At least 30% to 40% were duplicates. I removed and I told my father to take only this medicine. So basically, I was a deprescribing, and one point of time, my father places more faith on a doctor than me, even though I'm a clinical pharmacist. Still, that always they have a faith on doctors. That's a good thing because that's important, the faith and trust. Then I told my father to say that he's taking the medicine A, atorvastatin, and now rosuvastatin. Which one he should take? Then he discussed with the clinician, and clinician told, take only one medicine. True, we don't want the second medicine. So it's that way. That means basically when there is a time for review, definitely these kind of decisions will take. It is not that doctors doesn't want to take or clinician doesn't want to take such decisions, but nobody has time to do the review and take into consideration this polypharmacy. Okay, so the deprescribing is an important way of handling this polypharmacy, but it should happen after a thorough review. Okay, and finally, the goal is to reduce someone's medicine burden, but not necessarily just to to reduce the cost of treatment or something. They should not feel just to reduce the cost we have removed certain drugs. No, they should feel there is genuinely a need for reduced medicine to improve the health. So that is where this deprescribing concept is coming. Yeah, somebody's mic is on, please switch on mic.
I request all the delegates, please, except the speaker, please put all your audio system in a mute mode. I request again, the delegates, put your audio in a mute mode. Sorry for the interruption, Dr. Raj.
No, thank you. Okay. So the other important concept, at least in the Western part of the world, is social prescribing. It's more important. Why? We, at least in India, a lot of people have something called family support, social support. We call that social support. Like somebody is there in the home, our extended neighborhood, relatives, family, friends, all those people to talk about the health and other conditions. And so that gives some kind of relief in a lot of scenarios, and that helps. We don't realize the value of that family and family support and extended help normally. But in Western world, a lot of these people, elderly people, they live in like something called care homes or elderly care homes or nursing homes. In all those places they live, and there may not be people other than somebody occasionally visits. Nobody will be there to talk. They will be in their room, and probably the other person in the next room might be also sick. He or she may not be in a position to talk to you. So there is nobody to talk. So now, like when it's almost, like a jail, I would say. In the sense, if nobody is there throughout the day, at least somebody giving food and other things, rest of the time there is nobody to talk, then you will feel like completely isolated, right? Now what happens? That isolation will lead to, especially, all mental problems, social, psychological issues, like depression, anxiety, and a lot of other stuff will come. And when a doctor visits and the patient will complain, this, I had a palpitation, I did not sleep, I got this, doctor will immediately prescribe another medicine to make you sleep or reduce your anxiety or reduce your antidepressant medications. Now, these medicines by themselves can create at least another half a dozen problems. So now you understand, it's very important for these people to talk with somebody. If you talk with somebody, you can avoid a lot of further prescription. So what happens? There is something called social prescribing. It's not needed in our country, but it may be needed. Like a lot of elderly people are living, but the kids are away, far away, and there is nobody to talk. So there is a reference to make to a local non-clinical service. There is a service like there will be, maybe college students and healthcare center, they will have some volunteers. They will gather these people, elderly people. They will put them in some kind of group activity, maybe arts or group learning or gardening or a social activity or some kind of activities. They will put these people. Maybe somebody will visit these people, or they will be visiting the children's places and all those. That way, what happens? The people are kept engaged, and they are away from all this, psychological and or mental related issues. So that reduces, like, the elderly people lot of the pill burden. If you are giving by these activities, they kept active. By that way, they don't feel the pain, they don't feel all this depression, loneliness, anxiety, all those things. When you remove those set of medicines away from the patients, now what happens? They will stay with only minimum essential medicine. By that way, we can reduce unnecessary pill burden. And those medicines then, especially, are very nasty. They are not very friendly to the system, and they will cause a lot of adverse effects. So there is something called social prescribing wherever possible to reduce the pill burden. That's beyond medicine. That's also part of the healthcare system. We have to, even pharmacists, now everybody has to look the patient as a whole, not as a system. Patient can complain with some kind of leg pain. Because of the leg pain, the patient is not able to walk and go to a park. So they are lonely and feeling depressed, and then you start giving nice medicine. Rather, you find better to arrange a wheelchair or something, somebody to push them to the park. So that way they will meet somebody, and there is no need for this antidepressant medicine. So that's very important. So there is a need for social prescribing to avoid unnecessary polypharmacy. And another problem, I'm telling, especially the slide with blue color boxes, each slide is worth a project for any pharmacy student, pharmacy practitioner, students who are working with patient pharmacy background. Absolutely, each one can be taken. Take this keyword and look into what happens in this area, and you can find number of papers in this concept. And definitely, we can work on a project and find a way to help patients. Medication creep. Next one. When someone continues to take medicine, even if they are not benefiting from it or no longer needed. So this can be understood by careful review. The patients, imagine, as I was mentioning earlier, the patient had a leg pain or a joint pain, and they were taking like an analgesic, and now that they're all right, but they don't know that actually which medicine given for especially that pain and all. They will continue to take the medicine, and the medicine will continue. If you don't investigate, it will be there for a long time. Many times for asthma patients and the patient with inflammatory disorder, steroids will be prescribed, and there is a tapered way of reducing steroid. If it is not done, the patient did not visit the clinic, or somebody did not monitor, that steroid prescription will be there forever, for a long time. The patient may just feel better, but steroids will have long-term consequences in the health and a lot of adverse. I've seen a patient, the asthmatic patient, taking steroid for like 3 years and coming with all steroid-related adverse effects. And then you have to treat that very vigorously. So that much is the problem of this medication creep. That means every time patient takes a new medicine, there should be given with specific deadline to stop this medicine, if that has to be stopped. If that has to be changed, definitely there has to be an advice accordingly. The prescription should have certain medicines in red color letter with 3 months, written in their local language, be it in Hindi, Telugu, Kannada, Malayalam, whatever the language. You have to write and say for 3 months only, for 1 month only. And your hypertensive medicine, it will be continued, and you can say review after 3 months or review after 6 months. This will, the medicines, whichever supposed to take in the short term, should be in a separate place in different color in a prescription. So everybody will understand this medicine should not be there after 7 months, not after February, something like that. So that the patients will go back to the doctor. That time they'll tell, I'm taking this medicine, whether to take or not. They will ask, okay, do you have a leg pain? No. Okay. You don't have an acidity problem? Okay, stop omeprazole. So like that, there are a number of ways we can really control this medication creep, and it is absolutely important for the clinician and pharmacist to review the prescription. Don't overload prescription, and wherever possible, cut down this prescription. That way we can maintain this healthy aging. The aging will be healthy only if you have minimum number of medicines. By not having like 25 medicines, we are not going to keep the patients healthy. So that's keep an elderly patient healthy. If those medicines are minimal and there are no problems, and they'll be go on with their normal life and they'll be fine. If with minimal medicines, but unnecessary medicines and unnecessary polypharmacy is a problem. Polypharmacy and frailty. We know the elderly age will bring frailty, but that polypharmacy itself will give the frailty. That means the weakness due to the medicines. I would say weakness and sickness due to the medicines. Okay, so the multiple health challenge deficits means someone living with frailty taking multiple medicines to help with these challenges. Okay, at the same time, because of the effects of inappropriate polypharmacy, this itself can cause further frailty. The weakness and age-related problems will be aggravated by more medicines. It's not helping all the time. Okay, so they should be taking only the right medicines, and polypharmacy is a factor contributing to the elderly frailty. It's not only the age-related frailty, medication-related frailty is also there that has to be taken care. So medicines, more of it, not necessarily help. So the clinician and the healthcare provider and the pharmacist have to carefully look in what ways we can reduce the number of medicines. They keep it to a bare minimum, and therefore the patient will operate, because everything has a cost benefit. There is nothing called safest medicine in the world. Every medicine has the adverse effect, some cost associated with it in terms of your health. So keep it to the bare minimum. Keep it with only essential required medicines. We can't say, no, you can remove all the medicines and keep it only that. No, patient has a leg problem, serious problem, you have to give it. There is no way. But how to keep it minimal and what are the other non-pharmacotherapy approaches, everything have to be explored. So what needs to change? So there should be zero tolerance to inappropriate polypharmacy. So if there is an unnecessary medicine, unnecessary increasing too many medicines, there should be zero tolerance. You have to find a way to reduce it, cut it. Okay, healthcare team should aim in such a way that they understand the implications of this inappropriate polypharmacy, and patient should also understand. Like sometimes patient likes the A medicine, B medicine, they feel better with one medicine and they want to continue. No, we have to educate. The least possible medicine is the best way to give. There is no way you can get all your health from medicines. So that part, healthcare provider and the patient should both have that in the mind. There are concepts of stop, SOPP, STOPP, start, and PINSA. These are all various models in which appropriate medicine will be given wherever needed. The stop criteria will be used and the medicine will be stopped when needed. It will be started. Each is a keyword for further kind of research in this area, elderly polypharmacy area. Somebody can research on this area. They are interested. So whenever someone is prescribed with a medicine or a medicine review, they must be provided with clear information. So we should not just dump all the medicine and say, take this in the morning, afternoon, evening, but we should tell why this medicine has been taken. So that avoids a lot of problems. When you say this problem is only for this particular pain or this illness, when the illness become all right, they only will ask whether to take this medicine, I'm all right now. Then we should be happily reviewing it, removing the medicine, unnecessary medicine. So that's why it's important to help either the elderly people or their caretaker. Explain that clearly. That way, they only will keep a watch on this medicine and ingrain this concept in the beginning itself that unnecessary medicine should be avoided from the beginning. So that way, they will also keep an eye on that. When needed, they will add. When it is not needed, they will inform the healthcare provider so that they can actually remove that medicine wherever possible. So they have to understand. Everybody has to understand the patient and their caregiver on these treatment goals and how this should be attained. And wherever possible, this medication review should happen. See, that's what not happening. At least in our country, If a patient actually even go to the clinician with all the medicines and explain, spend some time with clinicians or a pharmacist and tell what medicine is for what, and then based on that, patient can discuss with the clinician, and that can be actually changed. So there is a need for this kind of thorough review, and in that review, you can understand a lot of problems. Personally, I would say one example from my experience. One of my uncle was taking some kind of diuretics, and originally the diuretics, which will increase the urine flow, and it is used for cardiovascular complication, hypertension, all that, which is supposed to take in the morning or before like 3 o'clock in the day, because the diuretics, for example, Lasix, furosemide, will have effects for 6 hours. That means if you start by 4 o'clock, at least till 10 o'clock, the urine flow will be there, and the patient has to go to washrooms frequently, right? And how this happened, we don't know. And my uncle is taking this diuretics with night dinner time, after dinner time, like night 8 o'clock, he's taking the diuretics. What happened? So he's not able to sleep. Like every half an hour, he goes to washroom. Diuretics will do that. He doesn't know that. And then he went to a urology doctor. So urology doctor felt, okay, you have some kind of bladder control issue. Like that, he gave another medicine, because night he is not able to. He doesn't know that this patient is taking a diuretics, and he gave a bladder control medicine which will control the bladder, so that you will not have that urinary avoidance problem. He gave a second medicine, third medicine. Now you see the mess. Which is the medicine which is supposed to be taken in the daytime, no problem. You can go to the washroom. But nighttime, after 9 o'clock, he's supposed to sleep, but he's going to the washroom till morning 3 o'clock. And that he's sleeping to lack of sleep. He's an elderly patient. Because of lack of sleep, he's getting the sleeplessness. And what will happen? Elderly people, lack of sleep, they may, when we go to washroom, they may fall off, skip. Now you see the cascade, that's a prescribing cascade. And we don't know when this drug was taken, and leading to creepiness, that unnecessarily is taking this medicine. You could have given one other anti-hypertensive medicine, the problem is solved. Simple. But he's taking this medicine, that too in the night time, and going to another expert without telling what is the problem, other medicine, and he is giving considering as a urology problem. You see the cascade creeping, and polypharmacy, elderly, everything is there in this one. I just discussed with them, the doctor and everything. We removed one diuretic, and he's all right. He's sleeping and he's fine. So that's what the importance of this review. A simple, you don't need, there is no rocket science also. Everybody can do. You can do. Any pharmacist, any healthcare provider can do. We understand the basics of this, the medicines. So, and then that's what the systematic review and reconciling, it's called the term medication reconciliation. If you type in, you have hundreds of articles in the area to research for any youngsters. Okay, so reconciling means we are taking the past history, past medication, current medication, how much of the past medication has been there, and whether it has to be there. Or sometimes what happens, most important medicine will be missed. That's also a serious problem. Patient has diabetes, and the patient, now when we are discharging, we are not considering that, and somehow the patient is all right now, we skip the metformin, and next week or sometime the patient will come with high blood glucose problem. Okay, so the reconciliation is important, and the current prescription and the previous prescription, everything has to be reconciled, and then make sure that finally the essential medicines are only there, important medicines, other medicine should not be there. That clinician and the who is taking care should understand this. Okay, so especially hospital discharges and moving from hospital to general care, that means you are going to a regular doctor, they should reconcile the prescription. They have a prescription, they have another prescription, and they are not matching, duplicating medicines are there, then we should reconcile. That's where the reconciliation will also help. So they say, at least in Western world, they say you have to have a clinical pharmacy person who follows all these medicines and give appropriate management, and they review and support this patient on a continuous basis. So that what happens, the doctor's visit is there, medicine is done, but somebody will take care of this medicine and make sure that only right medicines are there. So this could be provided by a community or other pharmacists also. The pharmacist nearby the nursing home can visit and make sure that it is all right, and patient will be taken care. So this has to be there. That's where the pharmacists have to take care of this elderly, the polypharmacy issue as one of the core competencies. So whoever is working with the elderly people, the polypharmacy management should be a core competency. And that is going to save a lot of adverse drug reaction issues. Elderly people, just by have one giddiness patient will fall in bathroom, leading to major hip fracture that will put the patient bed, and all the lakhs of rupees are spent on that bedridden patient, right? One just medicine which cost a giddiness can make it happen, right? So that's where it's important. So adverse impact of polypharmacy should be understood, and patient should be checked. Like any medicine which is causing giddiness is absolutely dangerous. It might be for young people, giddiness, they'll sleep off and they'll become all right. But the elderly person, when they can, that will be there for a long time. When they go for a washroom, that's done. Many people, elderly people, skip and fall in the washroom, and that is leading to a lot of hospitalization problem. That's the impact of this polypharmacy. So, and that is this polypharmacy is against the healthy aging concept. That's what I want to highlight to the participants here. And then again, elderly people, they will have other problem, dementia. They will forgetfulness will start starting. So even those people, we have to find a ways to explain and way to make them understand the issue. They will also be discussed. And then finally, you manage this polypharmacy. And those people, we have to find ways and means to, they can remember the medicine. They will give an alarm, reminder call in such a way that they take medicine in the right way and appropriate medicine, and avoid like unnecessary medicine. All that should happen, especially in elderly people with dementia. So in summary, it's an important aspect to be considered, especially in the treatment of elderly people. And it has to be tackled by healthcare provider and other healthcare members in the team and caregiver. And they have to be involved in all the decisions. You can't just say, take this medicine morning, afternoon, evening. You just actually have to explain them, make them a stakeholder, make them understand, so that they will help you in the long way to, in the long run, to avoid the complication. That will help us take care of them in a better way. Definitely pharmacists, clinical pharmacists, or any pharmacist, if they put their mind into this work, and they can really help in this scenario. And then monitoring and follow, working with the people, de-prescribing, reducing the drug creep, and avoid this prescribing cascade. All of that will help, these people to have an appropriate therapy with, for example, minimal therapy with least possible adverse effect and good quality of life in the elderly age. So that's what I want to highlight to this August audience today morning. Thanks for giving an opportunity, and I'm ready to answer any questions if there are. Thank you all.
Yeah, thank you so much, Dr. Rajan. It was a wonderful session. Hope most of the delegates or so are in the students community, they could have got more idea how to handle the geriatric patients for the healthy aging. Now the session is open to the question and answer session. Before that, I request Dr. Subhash Marihal sir as well as Nilesh sir to join the question and answer session. Before going to the question and answer session, I request Dr. Marihal sir to summarize about our today's speaker's presentation. Dr. Marihal sir, over to you.
Thank you, Rajan. Very nice presentation. And we are of a previous generation. Okay. So our days, hospital from Hassan was there. And I started my career in 1983, teach only from Hassan Hospital Pharmacy. So now a lot of things have come up, and young generation people have come up, and just like Western things, and I mean, our India also is clinical pharmacy, drug awareness, and clinical pharmacists are coming now. So this conference is under very nice, and also the Dr. Rajan's presentation gives a new rethinking to the existing community pharmacist and budding pharmacist. So in this way, we have to groom our people and educate our people, elderly people, and everybody about the drug awareness and the importance of clinical pharmacy, optimum use of drugs, and the drug interactions, food and drug interaction, it should be awareness again to created among the public. So with this platform, now we professionals are discussing. Now we professionals have to go to grassroots level in and around us. First, start giving awareness of the importance of the medicines and appropriate use of medicines and awareness. So these are my some views. So I tell to the chairman of the session, the young and dynamic person. So you highlight more points of the present relevance.
Thank you very much. Thank you. Am I audible, ma'am?
Yes, sir. Yes, sir.
Yeah. Okay. I'm extremely grateful to Dr. Rajan for his perpetual passion and extensive information shared during the session. Definitely, it was breathtaking and awesome session. Sir has nicely justified that how polypharmacy leads to adverse drug reaction and considered as inappropriate medication. Sir explained various concepts with clinically proven examples like doubling up, prescribing cascade, de-prescribing, social prescribing, medication creep, polypharmacy and fallacy, zero tolerance to inappropriate polypharmacy, reviewing the prescription based on clinical aspects to avoid inappropriate medication. Sir also explained the role and response. It is most important. It's the role and responsibility of clinical pharmacists to monitor and control the inappropriate medication complications. Thank you for remarkable knowledge and for highlighting the clinical relevant examples, sir. Now, as the chair of the session, it's my honor to propose closing remarks for today's session of Second International Conference. It was an honor more than pride to be present for this incredible session. Today's speaker have given informative insights which are valuable for one and all, especially for the budding researchers who can start their research on this clinical aspects and clinical problems of polypharmacy. With profound happiness, I would like to say that organizers have done wonderful job. Thank you all the participants and team organizers for inviting me. Thank you very much, sir. Thank you. Madam, please unmute yourself.
Yeah, thank you. I'm sorry for the interruption. So it's open to now the question and answer session. Now I open up the session for the delegates to raise the questions to the speaker. This one in mind, we can connect you. You can raise your hand or you can write in the chat box. Dr. Rajan, with the curiosity, I want to raise this question. Dr. Rajan? Yeah, I think I can understand the technical glitches from the Dr. Rajan's side. Yeah. I think it's the right time. We can utilize, we can give the opportunity to the delegates. You can mention your questions in the chat box. We can discuss with Dr. Rajan. Soon he will be connected. All right.
I think he already covered all the topic based on his theme.
Yes, joined. We have joined. Just a minute. Yeah, Dr. Yan Chandran have raised the question. Yeah.
Good morning to all of my APSC members. I am not going to ask any questions. It is just because yesterday I could not join. I felt very sad. So today Dr. Joshi has given me opportunity and about healthy aging. Because as Dr. Milind Pali said in the early episode, aging is a natural phenomenon. But as the mind is the only thing that when you think that you are age, you are age. Because physiological aging he was telling, but mind is younger. Whether you are 70 years, 60 years, 80 years, 90 years. So that is the most important. When you feel young, you are young. And Dr. Sullivan Rajan, I could not hear, but anyway, he has given excellent presentation because one of the eminent speakers he has given, and it is a very good platform for our young budding students and all research scientists because human values are most important. human touch is most important. Enhancing their knowledge about, because we don't know, we cannot say we know everything. We know something because our knowledge is ocean. We have learned a little ocean of drop of our knowledge. So we can keep on. APSC is one of the main agenda is to enhance the potentials of all the young budding scientists. So with these few remarks, I will just hand over the floor to Madam. Please continue.
Yeah, thank you, sir. Thank you so much. Dr. Rajan, from my side, that question, just with the curiosity, I'm asking this question. How about the budding pharmacists can you able to add up more point about the pharmacometrics, how it's going to help in the pharmacy profession?
So you're asking about your tangential question outside this particular theme. So pharmacometrics, it's kind of it's our own responsibility. So it's a part of pharmacokinetic, pharmacodynamic modeling. That's what we do all the time, pharmacists. But I'm looking at the way like how this pharmacometrics are, this PKPD models, everything can be taken to the clinics where we can be near the bedside, elderly patient, young, all the vulnerable group of people also. We can do the pharmacokinetic studies with minimal sample, and then that way we can actually help the patients one side. And to deliver all those care, the youngsters, our youngsters should step up. That means we have to, we are from a pharmacist, originally we are mathematically intensive profession. We are compounders. Compounder now they'll think some kind of attendant. No, compounding is a profession, and we are mathematically sound. We take all the components and calculate, recalculate, do all this, formulation, everything. We are very mathematically intensive. We have to take that mathematic intensiveness of our original, that is our root of our profession, to take it to the pharmacokinetic and dynamics. Same mathematics will apply and do that. That's what original, we are the compounder. Compounder means calculate, compound, and evaluate. Same thing we have to do in the clinics also, in the bedside, understand. So that's where pharmacometrics, my area, is playing a role. And there are training programs will come from multiple societies, SOFAs and code. Students can definitely take up those training and try to use those in the bedside and find the welfare of the patients. Yes. Thank you, ma'am, for asking this question.
Thank you. I think the one more last question can we take up now? There is a question from Habib Unnisa. We know polypharmacy is a big issue still in many hospitals. Polypharmacy is going on. What the reason? Whether it is prescription cascades or de-prescription?
Yeah, prescription cascade is happening. De-prescription is not happening. Okay. One, we don't know what is scenarios, multiple scenarios. One thing for sure, the focus is not on the holistic health of patients. But now we are so much specialized, meaning so much segmented. Cardiology patient, doctor will look at the cardiology side. He will prescribe and go. I know there is a personal, everything I have a personal example. There are my friend's father admitted in one of our known hospital. He's a cardiology problem. They put a stent and everything. So he's supposed to be in the bed for 2-3 days, right? When you are in bed, you will put a urinary catheter, right? Urinary catheter. So what happens, that urinary catheter is not monitored or something. After the stent, you are supposed to go out of the hospital in 48 hours. That is a stent. But urinary catheter they introduced in the urethra caused urinary infection, caused fever, infection, all those things. Now, because of that, what happened? Urinary infection because of this catheter, they have to start an antibiotic and other particular, and the patient stayed for another 4-5 days, and the patient cannot move or take rest, so they have to be put in ICU for some day, then moved up. Now, see, one urinary catheter, or they could have given appropriate prophylaxis of an antimicrobial, could have avoided that urinary tract infection. And because of that, the 4 patients stayed another 5 days extra and 2 days in ICU because of that. So what happens now? You see the cascade in the cast and therapy. So that means appropriate review. Maybe the cardiologist is so much busy and he took care of the heart. What about the urinary catheter you introduced on the urethra? Who will take care of that? That's still, some nurses will introduce, and that's fine. But doctor is looking at the heart. What about the urinary bladder? But that is because of the patient is not getting discharged from the hospital. That means Any specialist, in my opinion, any specialist who is treating the patient should not treat by specialist only. Specialist from a general medicine doctor, cardiologist plus general medicine doctor, psychiatry plus general medicine doctor, nephrology plus general medicine doctor. Like that, you always have to have a general medicine practitioner, and plus maybe clinical pharmacist, uh, there to review. So like that, a team should be there. Specialist should not treat the patient alone, even though it's a cardiology patient. What about the diabetes or other complication coming, and the cardiologist may not focus. So always specialist admission should be managed along with the generalist doctor. That's what my understanding, because I know who will take care of the something else is there. General doctor will look at the every complaint he will take care. So general medicine clinicians are absolutely important along with specialists, whatever specialists are needed. So that way we can reduce this a lot of complications. And my experience, pharmacists delivering the best care. What to say? These kind of situations, like as I gave you example here, when simple Lasix administered in the evening is more dangerous for an elderly patient. So I personally reviewed and did like this. Our students also do a lot of this medication review and avoid this unnecessary problem wherever possible, especially when the patient is being discharged. We do this reconciliation, medication reconciliation, reduce these complications and problem. So that way, a lot of examples are there, and none of it is like many of this are published, but as a book or sharing these experiences should happen from multiple places. So in realistic presentation, realistic case scenario where the pharmacist help. So that will give a motivation for other people to take care of similar endeavors in their respective centers.
Yeah. Nice answer. Thank you. Thank you, Dr. Rajan. I request Dr. Marihal sir and Dr. Nilesh. I request Dr. Nilesh sir and Dr. Marihal sir to convey our sincere thanks and as well as appreciation in the and the token of love in the form of appreciation certificate to Dr. Rajan. I request for the certificate honoring Dr. Marihal sir as well as Dr. Nilesh sir to join together. Over to you, sir. Dr. Nilesh.
Thank you, Dr. Rajan, for sharing remarkable knowledge and for highlighting a very good session with all the audience and participants. And I also congratulate all the members of team organizing for organizing such a wonderful session. Thank you. Thank you very much.
Thank you. Thank you, Dr. Marihal sir, and thank you, Dr. Nilesh. And once again, we want to highlight our sincere thanks from the APSC. On behalf of APSC, I take this opportunity to thank Dr. Rajan. Your collaboration is we need much more to know about in the pharmacometrics. In the coming up days, we will think about it. And thank you for joining and giving your valuable time for the APSC. Thank you once again, Dr. Rajan.
Thank you, everyone. Thank you, Marcus.
Let me move into the next session, day 2, talk 2. For this, I request Dr. Renu and Dr. Neeraja Verma to chair the session. Dr. Renu Karnakaran is currently working as a principal in Ram Gopal College of Pharmacy, Gurugram. And Dr. Renu received his doctorate and post-graduation in pharmacology from Guru Jambheshwar University of Science and Technology, Ichar, under the supreme guidance of our president of APSC, Dr. Milind Parlisa. His total experience is around 16 years, and the total publications in both national and international journals, which is around more than 16. And that Dr. Renu have contributed 2 book chapters in the very reputed books, and presented her talks in the national as well as international conferences. And Dr. Renu hold the second patent in various for her research projects. in the case of development of instrument for inducing psychosis in laboratory animals. And Dr. Renu won the second prize for best poster for M-Pharm research work. And Dr. Renu is a APTI and IPGA professional membership. Moving to our co-chair of our today's second talk, Dr. Neeraja Verma. Dr. Neeraja Verma, she's working as a Dean Academics at Goel Institute of Pharmacy, Faizabad, Lucknow. She completed her doctorate from Shiksha Anusandhan University, Odisha, and completed her M.Pharm from Bundelkhand University, Jhansi. Her B.Pharm from UPTU, Lucknow, and completed her D.Pharm from Lakshmipur in the year 1999. Dr. Neeraja, she had more than 17 years of professional experience in teaching and research, and she published more than 22 research papers, both are highly indexed journals, and she has made scientific deliberations in many national as well as international conferences, and invited for many invited lectures in various institutions. And she's currently guiding 5 PhD scholars and 3 M.Pharm students, and the 12 students for the PhD degree she have already guided. Without wasting the valuable time of our speaker, I'll hand over the session to Dr. Renu and Dr. Neeraja. Over to you, ma'am. I request Dr. Renu and Dr. Neeraja to chair the session. Over to you.
Okay, thank you, ma'am.
Thank you.
Should I start, ma'am?
Yes, please. Yes, please.
Okay. I would like to introduce our next speaker, Dr. Rohini Karnakaran. Madam is currently working as Associate Professor in Faculty of Medicine, AMS University, Malaysia. There she is performing certain administrative and teaching responsibilities like she's worked like preclinical and medical education unit coordinator. And then her education qualification is PhD in biochemistry, and along with that, she has done certain other master's degrees, like she's holding a master's degree in clinical microbiology, bachelor's in education, MBA in education management, postgraduate diploma in forensic sciences, human rights, medical laboratory technology, and bioinformatics. And for her further introduction, I would like to hand over it to Dr. Neeraj.
Thank you, ma'am.
Okay.
I want to continue. She is also certified QMS and IASO internal auditor for ISO 15189202112 and ISO 9001, that is in 2008. She is a winner of various international awards like the Young Scientist Award and winner of YSP Fellowships program in South Korea. She has published 50 research papers, 40 international conference proceedings, 6 books, and 10 chapters in books. She is also an editorial board member of many international journals and has reviewed more than 150 articles. She has presented oral papers and posters at international conferences in India, Malaysia, Singapore, Thailand, Hong Kong, Sri Lanka. She was invited speaker and resource persons for various international conferences. So welcome to ma'am, this international conference. Over to you, ma'am. Welcome, Rohini, ma'am.
Thank you, ma'am. It's a proud moment and I'm honored to be a part of your second international conference. Thanks to Neeraja ma'am and thanks to Renu ma'am and also to Manasa ma'am for this opportunity. Can I share the screen?
Yes, please.
Sure,
please, yeah. Can you please allow me to share the screen?
Yes, 1 minute. Dr. Neetu? Dr. Neetu? Technical team, can you please help us?
Dr. Mansadeepa, you are the host,
Yes.
so only you have to permit her.
All right. Ma'am, you can know.
Yeah,
now you can
I
share.
can do now, ma'am. Yeah, thank you so much. Okay, good afternoon, one and all. I guess there is a lot of students here. Thanks again to the organizers for inviting me to this conference, the second international conference on health aging. So we had speakers who were talking a lot about pharmacy and your pharmacy students. I'm here to tell you a little about nutrition and healthy aging. Are we ensuring the quality of life? So I'm Dr. Rohini. I'm from AIMS University, Malaysia. The question now is, we all age, we all celebrate our birthdays every year, but are we aging gracefully? Are we aging healthy? That's a common question in our mind. And we have researchers around the world who's associating and learning a lot about age-associated disorders, conditions, and so on. So what is healthy aging basically? So healthy aging is a process. This is a WHO definition, which is a process of developing and maintaining the functional ability that enables well-being in an older age. And we also have the WHO who has launched a number of frameworks, which is basically to support the countries and integrate the continuum of long-term care. Now, why is this? Because they have a policy framework and strategies, which is to demand for the long-term care and rising because of the aging of the population and the increase of chronic and degenerative diseases. So this has been a very crucial thing, and WHO is creating different policies and working on the policies to help this. So the framework for the countries is basically to achieve an integrated continuum of long-term care, which is to identify the key aspects that is necessary to achieve an integrated continuum of long care services by providing the existing healthcare and social care systems. So this framework is basically to strengthen the actions in accordance with the WHO Global Strategy and Action Plan of Aging and Health and the United Nations Decade of Health Aging, which is from 2021 until 2030. So they have prepared sustainable development goals, which is basically to facilitate the integration of long-term actions with the existing healthcare. Now, why are we talking all this about nutrition and what is this about healthy aging? So as we know, the food that we take in, the nutrition that we supply is not effective when it comes to old age because it begins from the infant until it goes to old age. So basically this WHO's framework is basically to optimize the functional ability over time and compensate for the loss of the intrinsic ability. So we have a number of things which can affect during the healthy aging, and WHO has a framework which works on it. And this policy framework along basically works on addressing older people's physical and basic needs, which is nothing about nutrition and hygiene. And also about the long-term care systems, which should promote the ability to move around. Basically at old age, you need to move around, you need to build and maintain relationships, learn, grow, decide, and contribute to the community as an elderly, which is very much important. Okay, so going into all this, we're talking about healthy aging and how is the nutrition in a healthy aging condition. So basically, we all have heard about the term programmed cell death. So we know the programmed cell death is a hypothesis, a theory that proposes that genes determine the lifespan of cells. So aging occurs as cells die. Okay, so we all grow older, we all celebrate our birthdays, but are we growing gracefully? Are we growing healthy? So as you become older, the number of cells contained, it decreases. Therefore, your functioning also declines based on the cell function. So as the tissues and organs, they lose the cells, the ability of the organism to maintain homeostasis also decreases. Therefore, there is a loss of cells throughout life, but it's not felt for a long time because we always have a reserve capacity. Okay, our body replenishes, our body fights infection, our body functions effectively for quite a period of time, after which there is no reserve capacity. So in general, when you talk about the young adults have reserve capacity of organs, it's 4 to 10 times. So you all have functioning which fights against infection, which is able to enable us to utilize our reserve capacity and make our organs function effectively. However, when it ages, when we age, the reserve capacity decreases, thereby the effect of aging becomes quite evident. So what happens is the wear and the tear hypothesis. It proposes that the aging is a result of accumulation of cellular damage. So the damage of the cells contribute to aging. So when you're talking about different rates of aging, basically it can be as functional ability, it can be intrinsic capacity, or it can be due to environmental factors. So when this is going on, the rate of aging also varies depending on the individual's function based on environment. When we say environment, the diseases that they acquire, the accidents or the toxins that they inhibit, and the lifestyle. The lifestyle modification has been a key thing. Nutrition, exercise, the amount of stress that you have, all this can bring about they can build upon the rate of aging. And genetics, so talking about the susceptibility of environmental stress and the ability to repair the cellular damage plays a very important role, where these all are the rates with which the aging is, whether it's increasing in a faster rate or in a later one. So talking about the aging process, our nutritional status is a very important thing which relies on the aging process. We're talking about cellular death, we're talking about nutrition. So nutrition supplement is one which protects your cell, which enables you to perform a number of actions. So there are a number of individual factors which can contribute to the aging process with the nutritional status, which is basically your medical and health status. So as we've already seen, the stress, any other chronic diseases, the oral health, the sensory changes, or physical and functional status like your balance, strength, another cognition, the physical ability, the mental ability, the cognition health, the emotional health, the nutrition, all this play a very important role in your aging process, which along with age, your genetics and gender plays a vital role. And other environmental factors, as I mentioned, your lifestyle. Lifestyle depends on the living environment, it depends on your social network, your cultural and religious traditions, your food availability, your medications, your health resources. All these play a very important role with your nutrition, along with your age, genetics, and the gender. So when you're talking about aging, we're talking about cellular damage and other details. So putting them in sequence, first is the molecular damage. What happens when there is a molecular changes? So what happens when there is DNA mutation or when there is a telomere change? We have learned about telomere when it comes to mutation. We have learned about telomere when it comes to DNA. So talking about telomere length or the DNA instability or epigenetic alterations can bring about aging at your molecular level. Okay, cellular level, deregulated signaling, mitochondrial dysfunction, all this can bring about the cellular aspect of aging. Physiological functions like inflammation, insulin sensitivity, diabetes can bring about physiological changes in the body leading to aging. The other functional is sensory, balance, strength, your physical, mental ability, the cardiovascular functions, all this can be due to the functional aspect of aging. And chronic diseases, if they have any diseases like Alzheimer's, diabetes, cancer, osteoporosis, or cardiovascular diseases, bring about early aging. So these are different multi-phased aspects of aging which can bring about aging, and the aging depends on every individual because of their molecular, cellular, physiological, functional, and chronic diseases that each of them acquire. So the caloric restriction, always talk about calorie, we talk about food, we talk about how we have to lose weight and so on. Yes, definitely calorie restriction increases lifespan. However, it does not change your immune mechanism. It does not change if you have an inflammatory response to the immune system. It does not change if there is an increase in the inflammatory response. It does not change if the person is diabetes or so, because diabetes can bring about other complications by reducing the blood glucose level. It can, and also due to cellular damage, which is limiting the oxidative damage. And also the stress mechanism, as you all, the coping mechanism, the stress that each of us go through cannot be restricted by calories. Okay, so this depends on the nutrition, that depends on the lifestyle modification, depends on the good healthy living of our individual. So talking about aging and talking about the immunology response and the cellular damage, there are different studies. There are studies which shows that aging is associated with dysregulated immune and inflammatory responses, which may be contributed to age-related diseases like cancer, infections, Alzheimer's disease, cardiovascular diseases, diabetes, and osteoporosis. As we know, most of us, at least one in our family today, are diabetes. So once you're 40, 45, and 50, the people start looking at whether you're diabetic, because that has become a common one and we have accepted it. But how far is it common? How far have we accepted it? And how are we treating? How is our lifestyle modification? All this become a question when it comes to healthy living, because healthy living, aging is a very crucial thing in today's thing, because managing ourselves during our healthy lifestyle and managing ourselves during an old age makes a big difference. So as you know, the immune system is compromised with different cell types as they engage in a complex series of interactions within the host and the pathogens. So these interactions under normal conditions are well regulated, and the inflammatory response, of course, the pathogen is finally dissolved, diminished, or removed from the body. However, in a normal condition, this is the thing that happens in a young individual or an individual with a healthy body. However, this does not associate with when it comes to an aging person or aging person with complications. So aging, inflammation with aging and T-cell function varies because aging is associated with this dysregulated immune and inflammatory response. What happens? Thereby exhibiting increased inflammation on one hand, and there is decreased T-cell mediated function on the other hand, which which causes various conditions related to it, leading to cellular damage. So what happens is with aging, your body also does a normal check in your body, because when there is an immune response, when there is an infection, your body fights against it. This happens in the normal and also happens in aging. However, is it being repaired when it is aging? That depends on the nutrition that we have taken in. So with aging, the normal checks and balances of the immune response is not effective and it is impaired, therefore creating a state of chronic inflammation. What happens in chronic inflammation? Hyperactivity of parts of the immune system, leading to innate immune response and thereby leading to cell-mediated immunity, particularly the T cells or the other. So what are the factors that can increase? So malnutrition is one common thing which happens in old age, because once you start, young age, all your body does is supplements, it protects, and you take in nutrients and you supply them with enough amount of food and intake. However, with old age, with aging, there is a risk of malnutrition. So there are different factors that can increase the risk of malnutrition among the elderly. When it comes to lack of nutrition, it's been a major concept. Lack of appetite, lack of exercise, healthy living, changes in the taste, smell, and vision. Diabetes can cause dental problems, so dental problems can associate with this. And when there is a poor supplement of nutrition, what can it cause? It can cause gastrointestinal changes. It can cause absorption defect. It can cause a number of other diseases associated also. And if a person is alcoholic, or does he or she has a kidney disease or diabetes or gastrointestinal disease, the nutrition absorption will be a great condition. Reduced absorption will lead to reduced utilization, leading to risk of malnutrition. So talking about nutrients, increased nutrient losses can also be noticed, where medications that can increase excretion of nutrients, and diseases causing gastrointestinal and kidney diseases. So consequences of malnutrition. Malnutrition can definitely cause a number of conditions, leading to decreased nutrition intake, increased nutrition need, thereby leading to muscle mass, leading accessibility of food, increased illness. Where they're ill, you start giving medications. When there is more medication, it again decreases the nutrient intake. And what happens when there is illness? There is decreased immune response. So malnutrition leads to a number of conditions which can definitely aggravate, and due to aging, it can bring about a lot of changes in aging, thereby decreasing the lifespan. It is from lifespan to healthy span. However, the lifespan decreases when there is malnutrition, especially in elderly, because of the nutrient defect. So basically, how do we support? We do have an elderly at home, okay, whom we can support, which is basically through the dietary quality. So the different ways in which you can build in nutrition among the healthy aging. One is the current belief about food. You have to give them the knowledge of healthy food. Healthy living is basically from a healthy, nutritious food. So that is one thing. The other things that can affect their healthy living is retirement, where they're working for years and they retire. So that could lead them to a mental, cognitive ability. So the mental ability could be disturbed. So we need to protect them based on their mental ability, give them positive things. And age-related conditions, as we have already seen, a number of conditions starting from, if they have diabetes at the age of 40, they continue with until 50s and 60s and 70s. So age-related conditions and disorders associated. The food environment. Are we looking at grabs and are we looking at different food that is being parceled? Are we looking at the tin foods? Are we looking at nutritious food? Nutrient means nutritious food. Nutrient means healthy food. So all these can impact the living of a person. And then psychological or personal support. They need a lot of psychological support when they are nearing aging and they're going old. You need to motivate them, give them moods when they might have mood swings, and you need to motivate them psychologically. And about the social engagement, the associations, their isolation can bring about a lot of aging factors which can aggravate aging. So community, family, friends can give in a lively life. And then the food habits, the regular food habits, which is a nutritious food habit, which provides nutrition, which has all the nutrition that is necessary for the old age. So all these can contribute to the diet quality, which can basically is a nutrition that will support the healthy aging. So talking about hygiene and nutrition, so we know that vitamins all play a very important role, and we know that nutritional problems exhibit mostly in the elderly because they're either undernutrition or they're overnutrition. Either they are obese or they're not consuming enough micronutrients that is required for the body. So when you talk about undernutrition, malnutrition, you talk about micronutrient deficiencies. Vitamins are very important. Vitamins like vitamin B, vitamin C, which fights immunity, vitamin E, selenium, zinc, calcium, iron, all these are required for the general living because these micronutrients based on the aging would be deficient and is required for the body. And same way when it goes to overnutrition, obesity can bring about a lot of cardiovascular disorders and other conditions where obesity must be treated too. So nutrition should be supplied in such a way that undernutrition and overnutrition based on every individual is recorded and monitored and being taken care of. Okay, so these age-associated nutritional problems, they provide opportunities and challenges in the developing interventions, which can therefore reduce inflammation, which basically improves the host defense and does not protect and does not prevent, against infection and does not help us in fighting against and basically preventing the cellular damage. Okay, so the strategies include single nutrient interventions, how you provide food. Example, foods rich in vitamin E, foods rich in vitamin B6, zinc, fish oils, or whole food with pre and probiotics. Pre and probiotics are essential when they are nutrition should be a very important supplement in an aging individual. And these are the general nutrition needs when it goes to men and women at different age groups, when there is requirement for the general nutrition, which is required for the body and which needs to be supplemented in the body. In addition, we also know the caloric restriction, depending on what is required to reduce inflammation and to induce immune response, to improve your immune response, and also to fight against infection and prevent cellular damage is very important. And your calories should be selected in such a way that it is specific and which can reduce inflammation and protect the body. So studies have also shown, several researchers have studied that strong evidence against appropriate nutritional intervention could optimize the immune and inflammatory response in older adults, leading to improved resistance to chronic and infectious diseases. So these interventions particularly started in earlier, but however, could have a significant public health implications for older adults. When talking about diet, researchers have also shown a wide range of 60 to 100 with varied genetic and socioeconomic backgrounds. So they do have nutritional status, which in turn reduces the effectiveness of the given intervention. So when we address these socioeconomic gaps and the genetic backgrounds, we can expedite the development of efficient and cost-effective nutritional strategies to improve the quality of life, especially in the aging or in the older adults. So talking about the quality of life, despite the existing aging conditions and nutrition and the quality of life in the older adults or aging, the systematic investigation in the field, research is still lacking. And we know the WHO has framework and they're working on it, and we have a number of other societies and membership associations working on it. However, the public health implications of nutrition and quality of life in older age is very important, and it's interconnected with a number of conditions like comorbidities, with enhanced by poor diet and nutritional deficiencies, and then polypharmacy, as Dr. Rajan has already mentioned in our earlier session, polypharmacy with a sequence of improper approach to healthy lifestyle, which is very important when you treat a patient, and then other social aspect and other psychological conditions which can makes a very big impact in a normal and the older age, and economic aspects like food insecurity, the being properly fed during the older age can all contribute to the well-being, to the nutrition and the quality of life of our elderly. And talking about the diet quality, not only the better diet, it is also associated with physical and emotional scores. As you know, the quality of life depends on the emotional score. Today, stress is being one common thing, so which can also deteriorate our health. So physical and emotional quality of health scores is with a better functional status will be an effective one, and with the impacted nutritional adequacy. So the definition of healthy aging, as we all know, the diet quality, the eating habits, the overall conditions, the disease-specific mortality, all this play a very important role in regulating your body, which can help you with a healthy aging. So diet quality is mainly defined in the presence of proper nutrient variety, adequate calorie intake, and which is very important, which can help our older adults. So researchers have also said that impact of administration of dietary supplement. As we know, as we grow old, we require dietary supplement which contains vitamins, minerals, herbs, botanical other compounds, amino acids, dietary substances, metabolites, and analysis of different subjects and research have shown that the supplement use have reduced the risk of stroke and cancer in the elderly. So it is very important that we regulate this, and it is very important we understand this and supplement required nutrients to the elderly. And researchers have already have assisted age-associated changes with microbiome, the population and the diversity of gut microbiome, and from age to death. So the intake of food is very important, as there is a rapid rise in the number and diversity of organisms from infancy to childhood, followed by the decline in the diversity among the elderly years. So talking about nutrient and drug interactions, as pharmacists, and you must know that drug interactions play a very important role, and the commonly used drugs that can cause nutritional deficiencies. A number of drugs can cause nutritional deficiencies. So when you need to supplement them if they are taking drugs, if they have any other comorbidities, if they have any other conditions, and they have to be treated. So the drugs that can cause nutritional deficiencies are based on antacids, anticonvulsants, antibiotics, antibacterial agents, anti-inflammatory agents, and anti-cancer drugs. So all these drug groups can potentially decrease the common ones like calcium, potassium, vitamin D, vitamin K, carnitine, and other substances like folate, vitamins like folate, riboflavin, and so on. So basically causing nutritional deficiency. So nutritional deficiency must be supplemented in their diet based on their individual conditions. So the other drugs that can cause nutritional deficiencies are diuretics, antihypertensive drugs. They must be definitely taking hypertensive drugs, antihypertensive drugs because they are got other comorbidities, hypercholesteremic agents. So all these can bring about potential deficiency of vitamin K, vitamin B6, potassium, calcium, magnesium, other substances like fat-soluble vitamins and water-soluble vitamins like riboflavin, and so on. So these drugs may cause nutritional deficiency and must be checked in for elderly. So keeping our adults healthy, we must look at the pyramid to steps to a healthier aging, and we need to cut down the calories, which is very important, and then looking for the right amount of food that should be given for the individual based on their healthy lifestyle. So based on their lifestyle with other conditions and steps that should be taken, the adults must take healthy diet, and the nutrition must be supplemented as grains, vegetables, fruits, milk, meat, and beans based on their age and the calorie intake. So healthy aging, we need to look at a number of factors. It's not just one factor. So there are a number of factors that must be looked into. Dietary resilience is associated with healthcare, age-related disorders, nutrition, social support, and other social, biological, and cognitive issues. So mental ability and other things will support and will aid too. So when there is effectively done, then the diet resilience will manage a good, healthy living. So when there is a deterioration in any of this, or when there is a lack of nutrition, when there is a lack of healthcare, when there is a lack of support, then leads to a negative imbalance. So healthy aging has a number of factors, and with nutrition is a very important one, which has to be supplemented based on their regular or based on their condition, each individual's condition. So healthy aging is required to promote health, prevent injury, and manage chronic conditions. Each one of us, we are young today, but tomorrow we are aging. Are we aging healthy? So have a successful aging, we must promote health, prevent injury, and manage chronic conditions. You must optimize your physical, cognitive, and mental health, which is very important for a healthy aging. And you must facilitate social engagement to have a healthy aging. So studies have also shown that effects of dietary diversity of healthy aging is very essential, and which contributes to physiological function and psychological function. So physiological function is disease associated, psychological is cognition, stress, and so on. So dietary diversity with healthy aging leads to a quality life. Okay. So studies have also shown that consumption of some good nutritional food may impact the aging process, and adherence to more adverse diet can promote a healthy aging process in elderly people. So are we all having the art of aging well? Are we all successfully aging? Depends on how successful we are. So successful aging is not, it is not just a term or a phrase which does not do justice to the inclusive opportunity that drive an individual to achieve an optimal lifespan. It's not about living till 80s and 90s, but however, are we living successfully? That is the most important thing. So the quality of equally important, the quantity of lives, both are determined together, and they give both controllable and uncontrollable impacting parameters. So most of the presenters either called out the terms such as functional ability or intrinsic ability, as I told you in the beginning. And these are most important points that we must look on. But however, when there is underlying physiological, sociological, psychosocial factors, health, lifestyle, behaviors, and other presence and absence of a disease determine whether they are successfully aging. So nutrition plays a very important role, and it has to be supplemented at the right time for the individual based on their normal, healthy living, and also based on their conditions related to the other factors. Thank you for the opportunity. Any questions?
So one talk, Dr. Rohini, it's really glad to be here with us. And there is a question from Dr. Jnanachandran.
Okay.
Please share your opinion about environmental pollutants of biological and chemical origin, about allergies and aging. This is a question from Dr. Jnanachandran.
Thank you, Prof, for asking this question. Definitely environmental pollutants with chemical agents that we use, starting from, it could be starting from the food intake, nutrition, or it could be basic living thing. Everything we look into have changed. The lifestyle has changed, which is built in number of adulterants, there's built in number of environmental pollutants, which could be food allergens, which can cause a number of things. So these can definitely change the lifestyle. So as we're talking about elderly, even a small change in the food diet, which contains pollutants, which contain toxins, can affect their body. So if we say a person who is 50 years or even 60 years with conditions of cardiovascular disease and, cardiovascular disease or a diabetes as such, diabetes, we consider every individual has diabetes and we treat them. However, even if diabetes, there are other complications. So environmental pollutants like, a general pollution can cause a number of allergies to the individual, and the drug intake can bring about many toxic effects. So there are a number of pollutants if I have to list two. So I'm just telling in general. So the pollutants will definitely cause allergies, which can affect the individual's health because of aging.
Well answered. Thank you. Thank you, Dr. Rohini. And now the question is open to the delegates. You can raise the question. Either you can post it in the chat box, or you can raise your hand so that we can connect you to the speaker. For this, I request Dr. Renu as well as Dr. Neeraja to join for the question and answer session. Dr. Renu and Dr. Neeraja.
Yeah, ma'am, I'm there, but Neeraja ma'am have left actually because of some her urgent work.
Yeah. Fine. Please take over the session, ma'am. Yeah. It's really very interesting, Dr. Rohini. With the curiosity, I would like to ask this question, since now, how to manage in the especially in the ladies after the menopausal, how they can continue for healthy aging. Can you able to help us for?
Yes, ma'am. So actually, menopausal, premenopausal and postmenopausal thing has been a very crucial thing for a woman. Going through that phase with hormonal changes has been a very important impact. So we need to take in supplement to protect ourselves, especially during these hormonal changes. We need a lot of resources, example like omega-6 fatty acids. All these supplements must be taken basically to balance our hormonal changes, which is required for every general well-being and the growth and balancing the hormone during every time. And then other than this, we need to look for the lifestyle changes and other hormones which hormone balance should be done with the nutrients. So right amount of nutrients must be supplied, especially the calcium, because osteoporosis in women is very common and it needs to be supplied with good amount of calcium. However, any nutrition must be taken only with a consultation with a physician, because the amount of food, or just because we know that calcium is required for the woman, it should not be taken as such. A good amount of nutrition as milk is a very good supplement as a calcium source. So those things must be taken. However, if it is taken in a medication form, it should be consulted with a consultant, with a physician before we consume any medication as nutrient, because that's very important.
Very
Hello.
true.
Hello,
Yes.
Deepa ma'am.
Yes.
Can I just spare 1 minute?
Yes, please. Yes, please.
Thank you, Dr. Rohini Karnakaran. I'm seeing you in the second platform. Already I know Madam in
Yes, sir.
Anti-Virus Research Society and Dr. P. Selvam. You have given an
Yes,
excellent
sir.
presentation about healthy aging and that pollutants allergy I inquired just because I am associated with the organization where we treat the allergy management. As you rightly said, because nowadays the young generation people, their exposure to sun is not much. They are all living in apartments. So there is chances that the absorption of vitamin D3 is very minimal. So we are giving a sun and moon tablets to the patients, which is containing sublingual tablets, sun and moon tablets in the form of sublingual tablets of about
That's quite
3000
interesting, Prof.
IU, 3000 IU of vitamin D3 and 1000 microgram of vitamin B12. So sublingual tablets, as you rightly said, to enhance immunity tolerance and to make the leaves long living of the cells, cellular. We are given a very excellent presentation. On behalf of APSC, it is my pleasure to congratulate you, and your knowledge is very useful for our society. Thank you, Dr. Rohini Karnakaran. Okay,
Thank you, Prof. Thank you.
Okay,
I definitely agree with Prof. Thank you.
Yeah, now I request Dr. Renu to take over. Yeah, Dr. Renu, you are. Yes.
Okay, I would like to thank Dr. Rohini ma'am for making our delegates aware of such an important topic. It was very important and very nice and very well presented in a basic way, ma'am. From the emotional and social health also. Ma'am, I'm audible. Hello.
Dr. Renu, we are. I think we can able to find some technical glitches from your side. Is it fine now?
Am I audible, ma'am?
Yes, please.
Yeah, yes, ma'am.
Yes, now you are.
Is it fine?
Yes, ma'am.
Yes, yes, we are audible.
Yeah.
Excellent. Please go ahead.
Oh,
yeah.
Okay. I would like to thank Dr. Professor Rohini ma'am for such a nice talk. Right? It was such a basic, and you correlated our diet, our social life, and our emotional health with our, you can say, with our aging. And basically, we also make aware of us like nutrition, which we are taking along with our medications, how it affects our nutrition supplements. It was such a basic and good, and you can say for laymen also, it was a very nice topic, ma'am. And how much nutrition we should take. So it was a very basic and nice topic, and for importance of nutrition in the immune health and the various phases of our life, how nutrition affects after 60 or during the menopause, which type of nutrient deficiency it can be. So it was such a, and basically of such a, you can see in a simple way, I would like to say. Thanks, ma'am. Thanks for the topic, and I would like to present the certificate.
Thank you, ma'am. Thank you so much.
Participation. Thanks, ma'am.
Thank you, Dr. Rohini.
Thanks a lot.
Thank you once again. From on behalf of APSC, I take this opportunity to honor you with the appreciation of token of love and appreciation of the certificate from APSC. And due course of time, we will send you through this certificate to your mail. Please receive from us. Thank you once again, being part of the Ichar, and sharing your valuable time and ideas with us. Thank you, Dr. Rohini. Moving to the next, thank you, ma'am. Moving to the next session. For that, I request Dr. Vivekananda Chatap as Dr. Vagish to join the Ichar and co-chairs for this I beg your pardon, Dr. Vivekananda Chatap to join for the challenge session. Dr. Vivekananda Chatap currently working as an assistant professor, Department of Pharmaceutics at Ichar Patel Institute of Pharmaceutical Education and Research, Karwanand Naka, Shirpur district. And Dr. Vivekananda sir received a grant from Indian Council for Clinical Education, Government of India under Research Promotion Scheme from 2019 and 20. He worked as a principal investigator, received a grant of rupees 13 lakh from Department of Science and Technology, Government of India for organizing Inspire Internship Science Camp and many more. He holding in his hand for the textbook of pharmaceutical biotechnology, and he published in the publishers like in various publications, and he have guided 39 MPharm students and 8 PhD students, and he has received many awards and many seminars across the country. So without wasting the valuable time of the speaker, I request Dr. Vivekananda Chatap sir to introduce our next speaker to the delegates. Over to you, sir.
Yeah, thank you, madam, for nicely read my brief introductions, giving my brief introductions. Before that, I would like to thank Dr. Hanumantajar Joshi sir, organizing this such a nice and good topic we have chosen. And this is the topic is need of the current scenario for organizing the second international conference on health, aging and research 2022 in association with, that is organized by, that is Association of Pharmaceutical Scientists and Educators, and in association with ICMR, Sharda Vilas College of Pharmacy and Amist University, Malaysia. And I would like to thanks for giving me opportunity to introduce today's speaker, Miss Neni Purvi Tasari. Purvi Tasari ma'am is a B.Pharm MSc doctorate candidates of Faculty of Pharmacy, Universities Erlangga, Surabaya, Indonesia. And ma'am is working in professional education in Master of Science on track at the School of Pharmaceutical Sciences, University of Science, Malaysia, Erlangga University, Surabaya, Indonesia. And ma'am is studied in the field of pharmacist, that is apothecary, and currently working as a staff of Department of Pharmacognosy and Phytochemistry, Faculty of Pharmacy, Erlangga Universities. And ma'am has achievements in various publications in several articles around in various international and national publications, and 8 seminars across the globe. Now I request, along with my co-chairperson, Sharda, Dr. Sharda Devre madam, to proceed for further sessions.
I request Dr. Sharda ma'am to share a few words.
Am I audible, sir?
Yes.
Yes. Thank you so much, Deepa ma'am, Joshi sir, and Sharda Vilas College of Pharmacy. It is really, the topic chosen is really wonderful, and it is near to or close to the all of us it's a day-to-day scenario, or it is the part of our research, or should be the part of research. I'm very thankful that I have given opportunity to co-chair this session for the respected Neni Purvi Tasari ma'am. She is going to talk on the Indonesian natural products for healthy aging. And as I'm working from since last 15 years on various medicinal plants, I'm also very eager to listen her. So without taking too much time, I would like to request Neni ma'am to start her session. Thank you, sir. Thank you, ma'am.
Yeah, thank you. Thank you so much, Dr. Sharda. And I request Dr. Neni to take over the session. It's over to you.
Thank you, Dr. Manasadipa and the chairperson, Dr. Vicky. Also Dr.
Sorry to interrupt, Dr. Neni. Sorry to stop. We are unable to hear you from your side.
Oh, Is it audible?
Partially. Well, partially. Some more we need.
Okay, I think this is audible. I try to replace my my earphone. Hello?
Yeah. Yet to. Yeah, this. Yes, Dr. Neni.
Neni, you can speak without microphone. That is better. Without earphone.
Yes, yes,
It's better.
I'm talking without my earphone. Is it audible? Hello, madam. Is it audible?
No, the volume is very less. It's very bleak.
Okay,
Why don't you try directly with the laptop?
yes, I tried
Without earphone?
already
Yeah.
without the earphone.
Yes.
Is it okay now?
Now it is okay.
Okay, thank you very much. Oh, I'm sorry, I have some issue with the earphone.
Okay.
Okay, thank you very much for inviting me as one of the speaker in this great event. Okay, thank you very much also for Dr. Hanumantaja Joshi and also the all of organizing committee of second international conference on healthy aging and research. Shall I share my slide, Doctor?
Yes, please. Yes,
Is
please.
it still disabled?
Yeah.
Disabled by host.
Just a minute. Just. Yes, now you can. Now you can.
Okay, I will try, ma'am. Is it visible, ma'am?
Yes, visible. Fantastic.
Okay, today I'm going to talk about the Indonesian natural product for healthy aging. Okay, my name is Neni Purwitasari. I am the lecturer in Faculty of Pharmacy, Universitas Airlangga, Surabaya, Indonesia. Greeting from Surabaya, everyone. So I would like to first with this quote from the prominent actress, Hollywood prominent actress, Meryl Streep. She said that don't waste so much time worrying about your skin or your weight. Develop what you do and what you put your hands on in the world. But nowadays, I think we have to think about our skin and also our weight. Okay, so I would like to start with the aging process. As another speakers mentioned, that the aging process is a natural process that transform a healthy adult to be weaker gradually with the reduction in reserve in most physiological system, which will lead to increase the susceptibility to degenerative diseases and ultimate death. And the aging process also linked with the immune system, as Dr. Rohini mentioned earlier. And the aging process is a physiological process in living organism that caused by, among others, is free radicals. So one of the free radical related to skin aging is skin hyperpigmentation due to the excessive of melanin and due to the increasing of tyrosinase enzyme activities. So I would like to, in this occasion, I would like to highlight the healthy aging or in healthy skin. So as we know that the physical appearance is strongly influenced by aging of the skin. So the changes in skin appearance provide a visible sign of aging, including wrinkles, irregular pigmentation, sagging, and elastosis. So the skin appearance changes have an important impact on self-esteem and also social welfare. So what is our tradition offers to maintain the healthy skin? So I would like to highlight the Indonesian tradition that we have beauty care that is a total beauty system for body and mind. So for us Indonesian women, looking good is a way of life for every Indonesian woman. The traditional beauty secrets are taught alongside the philosophy that a woman is responsible for maintaining her own health and beauty, including young and healthy skin. So the main ingredients of Indonesian beauty products, from traditional making to modern packaging, are natural herbs, mostly as a natural herb, yeah. And they are scientifically proven to have benefits to maintain a healthy and young looking skin. The history. The art of total beauty is recorded in temple reliefs from the 9th to 17th centuries. But nobody at that time, nobody had access to these secret recipes without royal permission. So within the Balinese, lesson in health and beauty began in childhood. A Japanese princess or lady of the rank received daily massage and lulur. Lulur is an abrasive herbal paste from Indonesia. Lulur wrap that made from rice, flour rice especially, and also pulverized bark and many of flowers. So this paste leaves the skin soft, clean, smooth, and give Asian skin a golden glow. So in your later, it helps to slow the wrinkling and the aging process. In the history of Java book published in 1817, Sir Stanford Raffles noted that the Indonesian ladies love fragrance such as sandalwood, gandapura or marshmallow, kluangan, patchouli, or the Latin name is Pogestemon cabrit, orange, gaharu, gaharu is Aquilaria malacensis, and also kelemba or Java rhubarb oil. And today, women can enjoy the combination of kelemba, mangir bark used in body scrub creams, and a floral essence, which are the ingredient of the popular product called lulur. So what I'm going to talking about today is about the lulur. So they can also opt for natural oils made from sandalwood or akar wangi, which the Latin name of Vetiveria cisadoines, which smell wonderful on warm skin. So pulverized roots and leaves such as turmeric, rose myrtle, and temu giring. Temu giring is a type of ginger from family Gingibraceae, are used in a mixture of lulur and mangir to render the skin smooth, clean, and fragrant. So traditionally, the people of Java and Bali use lulur or body scrub to assist the prevention of the aging process. Lulur is a part of beauty care and body freshness in Javanese royal tradition since the 7th century. The use of lulur has also been a part of daily ritual for people of Java and Bali especially. Then one of the most well-known ingredient used in lulur in Java and Bali is temu giring. Temu giring is a curcuma heniana from family Gingibraceae. And traditionally, lulur temu giring is used by the priests to rejuvenate and soften the skin and eliminate bad odors on the body. Lulur temu giring is usually mixed with other ingredients such as rice flour, and then turmeric, pandan leaves, and also lime peel to form the natural scrub. We have many kind of lulur formulation, but I would like to emphasize on three most famous kind of lulur, which are Javanese and Balinese lulur. It is a yellow and white lulur, and Madurese lulur. So also is a actually literally is a black lulur, and also Borneo lulur. Okay. The first one is Javanese and Balinese lulur. We share a common and a similar culture, so that also impact on many aspects such as traditional medicine. And so we also share the similar skincare or body care, such as lulur. We have yellow and white lulur. So okay, I would like first I would like to show you that in Indonesia we have many of islands. So Java and Bali is very near. Within oval. I saw in the map is oval, red oval, and we have lulur from traditional to manufacturing packaging. Okay, I would like to highlight the main ingredients of yellow lulur. Yeah, yellow lulur because the color is yellow. The yellow comes from the ingredient which says curcuma heniana or temu giring, which is a gingibraceae family like turmeric and ginger, and also rice flour. And yes, curcuma heniana is native to tropical regions, especially in Indonesia, and it is traditionally used as a skincare since long time ago for cosmetic and also body freshness in Javanese and Balinese women, and has many other bioactivities such as antioxidant, anti-cancer, and also anti-inflammatory. So that we can see that the color of lulur is yellow. Yellow is due to the ingredient of curcuma heniana with the main compound is curcumin. So this is the work of our research group. One of our research group member, Dr. Ida Kusumawati, along with our collaborator from Hiroshima University. They published a paper entitled in Journal of Ethnopharmacology entitled Anti-Aging Properties of Curcuma heniana, scientific approach to its use in Javanese tradition. And we have the result. This result showed that a curcuminoid as a main compound of the curcuma heniana in crude extract of curcuma heniana play a significant role in antioxidant activity, and also had activity of a tyrosinase inhibitor and collagenase inhibitor. And this is also correspond to improvements in the appearance of UV-induced red skin histomorphometry with the parameters such as epidermal thickness, number of sunburn cell, collagen tissue, fibroblast, and elastin. So the in vivo assay results showed that the topical application of the crude extract of curcuma heniana produced the significant improvement effect on the UV-induced skin structure damage. So in conclusion, curcuma heniana contains antioxidants compound that has potent anti-aging activity. And the second one is white lulur. This is a very famous also in Indonesia. White lulur, the color is white because the main ingredient is bengkoang or Pachyrhizis erosus. Pachyrhizis erosus, this is a kind of rhizome. So it is known as a source of various active compound which can be used against free radicals to reduce the risk of skin aging through tyrosinase enzyme inhibitor. And bengkoang also has the benefit to maintain the healthier skin and remove the dead skin cells. And because it contains abundant of vitamin C, which can nourish the skin and can be used as a base material for the preparation of mask to refresh the face and brighten the skin. And this is the product of this example for the bengkoang lulur product, and the color is white. And sometimes people use it for whitening, but as our origin colors of skin is yellow, but I think that one is yes, very popular because yes, the influence of such as a Korean healthy skin is white. So now Indonesian women are trying to be as white as a Korean actress, but I think that one is not actually true because we have our origin skin, our origin skin color, and this is a good not to be white as a Korean skin, but to be yeah, at least we have a glowing skin, glowing Asian skin. So the research in anti-aging activities of Bengkuang, one of study in Bandung from Biomolecular and Biomedical Research Center in Bandung, Indonesia, examines the antioxidants and anti-tyrosinase properties of Pachyrezurosus peel extract and also the tuber. In this study, it's contained the saponin, tannin, triterpenoid, and terpenoid, while the tuber showed the presence of flavonoid, saponin, phenol, tannin, and alkaloid in phytochemical analysis. The antioxidant assay, and these two samples showed the higher DPPH scavenging activities, and also in anti-aging assay, that sample showed a higher tyrosinase inhibitor activities. Yes, this is the peel showed the higher tyrosinase inhibitor activities when compared to the tuber. And it can be concluded that the peel of this fruit or this tuber has an antioxidant and anti-aging activities effective for preventing the skin aging. So the second one, I would like to talk about the Maduris lulur. Maduris lulur comes from Madura Island. Madura Island is a small island near to Java Island. So the women in Madura and in Royal Sumeneb society, they use this beauty ritual for aging, for prevent skin aging by 3 steps. The first one is using the rice flour and curcuma heniana, and then the second one using the scrubbing from rice flour and eggshell. The eggshell is actually a function as exfoliating the dead skin. And the last one is black lulur. Black lulur is contained from activated charcoal as adsorbent obtained from the roasted rice. So these 3 steps of skincare, routine skincare, is originate from Maduris Royal Society. So that we can, it is the same in Javanese lulur. The main ingredient is we use the curcuma heniana or temu giring. It's a very popular in Indonesia. Okay, the last one is Borneo Lulu. Borneo is a huge island, is in red color in the map. So this Borneo Lulu, we call it ketan putih body scrub. Yes, it is not using Oryza sativa or rice flour, but it uses a sticky rice flour. The difference with the Javanese lulur. Is another anti-aging and rejuvenating treatment with traditional ingredient, which are mangrove or rambai padi, with the Latin name of Soneratia apetala. This is the plant is a kind of mangrove, and this also the product. The most popular is pupur rambai padi is for the face, and the last one is the lulur is for the body. The body color, the body lulur also in yellowish color, but the pupur or powder for the face or mask for the face is the color is white. So the research on the apetala as anti-aging, it is found for new compound. Research done by Xiang Ziyi in 2020 and Sujiang in 2022. There are 4 new compounds, soneradon A to D, A, B, C, D, and the 18 known compounds were obtained from the fruits of the mangrove Soneratia apetala. So the one compound, soneradon A, had the most significant anti-aging effects on Seonar Heboditis elegans. It's a nematode with the increasing the survival time. So moreover, This compound significantly attenuated aging-related decrease of pumping and bending of the worm in health span assay, suggesting that the great potential of anti-aging application. Okay, we also have some cream or traditional cream as cold cream. We call it bedak dingin. Bedak is mean dingin mean cold. So this bedak dingin cold cream we normally use as a mask for our face, and the main ingredient is rice flour as Oryza sativa, and it's sometimes added with the special herbs like pandan leaves, rose petal, and jasmine, and also lime peel. So the many research has reported that some strong antioxidants, including ferulic acid, gamma oryzanol, and also phytic acid, are present in Oryza sativa. And this is it is a traditional making of this cold cream. It's still using a very simple material. Right now we are I'm trying to emphasize the prospect of the natural product as a skincare product. And nowadays, the natural product skincare is growing rapidly, as most of women prefer the natural products rather than the chemicals product for their personal care. And the natural product skincare contains natural nutrients to improve and provide consumer satisfaction due to the relatively fewer side effects compared to a synthetic one. Indonesia is one of the biggest supplier countries for herbal and raw material in a skincare product. Many plants are available naturally, as well as the different uses that can be made as a basic ingredient for cosmetic preparation. So the Indonesian skincare product insight, we are about paying for the glow. So Indonesia is a country that abundant with the natural resources, and Indonesians grow up knowing that they can reliability count on them. It is no wonder that jamu, an Indonesian traditional herbal drink made of various spices, is considered as a national pride. So not only is considered as effective drink to deal with physical ailments, it's also good for cosmetic. So Indonesians are also increasingly become more aware on the use of chemical products in their daily lives. So while this can be attributed by how Indonesians are blessed to grow up with plentiful of natural resources to practically fulfill their day-to-day needs, the mass media in Indonesia has also been very keen to cover how exposure to chemical ingredients found in day-to-day items, including cosmetic and skincare, may bring a negative impact to health. So, in summaries, the key insight of Indonesia's skincare market, I have three key. The first one is beauty as an investment. So I think the beauty is a serious problem in Indonesia, especially for female population who often face the pressure to look good even from an early age. And the second one, natural beauty comes from natural product. We believe that natural beauty comes from natural product. For example, lulur that I mentioned before, Indonesian traditional scrub, and a jamu, which was mainly served to the royalties and nobles in Javanese karatons or royal palace, was said to be the secret of the beauty of the Japanese princess and in palace ladies. And the third one is halal goes to beyond food. As we know that Indonesia is we have a very big Muslim population, so the halal is a serious issue in our country. Naturally, the halal status of product becomes a big concern in foremost Indonesian, not only in food but also in what keep in touch to our skin. So halal certification is now deemed by the market also as a mark of quality and safety assurance. So the last in my talk, in summary, the natural product of Indonesia has a long history. It had been used for health, skin, and hair care. Indonesia has abundant natural plants that can be used as a source of the natural product skincare industry. So Indonesian also has a natural product so that good activities as anti-aging, as an antioxidant, tyrosinase inhibitor, collagenase inhibitor that keep the skin healthy and prevent the aging skin. And thus, Indonesia has a great opportunity to become one of the largest natural product skincare industry in the world. However, the further research need to be conducted in terms of formulation and also in product branding should be increased. So one last quote that I mentioned is aging is inevitable, but it can be slowed down. So having a healthy skin is a part of healthy aging. Yes, thank you very much, Madam and Sir. So you can contact me also through the email nannypn@ffunar.ac.id. Thank you very much.
Thank you, ma'am.
You're welcome.
It was an informative session. And now I would like to call Mr. Dr. Vivekananda, sir, to hand over the certificate to ma'am.
Yeah. Thank you, ma'am. Deliver a very nice presentations here and enlighten our that is Malaysian, Indonesian beauty products. Deliver the presentations is very nice and interactive, which will be helpful for the budding pharma scientists, which are work in the herbal, which specifically on the aging products. And I would like to present the certificates to Purvita Sari madam. Thank you.
Thank you. Thank you, sir. Yes, I received this.
Yeah.
Okay. Thank you. Thank you very much. Thank you for the
before that, I'm going to leave that. I would like to thanks Dr. Harmantrichar Joshi sir and Association of Pharmaceutical Scientists and Educators team. They're organizing very nice second international conference on healthy aging and research. Thank you.
Thank you, sir. Thank you, ma'am. Next, I would like to, next session will be done by Speaker S. Palanisomi, sir, and co-chairperson as Dr. Vakish. So I would like to invite both of them. And Dr. Vakish, so currently working as professor and vice principal for Pharmaceutics Department in St. John's College of Pharmaceutical Sciences. Sir has done his PhD from JGT University, Rajasthan in 2020, M.Pharm from National College of Pharmacy, from Trivandrum College of Pharmacy, TVM College of Pharmacy, Bellary. Sir has total professional and research experience of 13.8 years, and number of students he guided for B.Pharm research project and 50 students for PG project. Number of students guided for M.Pharm project as 20 students. Now I would like to welcome Dr. Vakish sir to introduce our speaker.
Hello, can you hear me?
Yes, sir. Sir, 1 second.
Okay.
So it's over to you, sir.
Yeah. So myself, just I would like to be a welcome for all our delegates, and I would like to be introduce all the welcome for the dignitaries for the second international conference on health, aging, and research, and which is organized by the Association of Pharmaceutical Sciences and Education and Associations of Indian Council of Medical Research, India, and also Sharda Vilas College of Pharmacy, Amnesty University, and Malaysia. And now I would like to invite the presenters for today's present session, Dr. S. Palaniswamy. Dr. Palaniswamy is an eminent academician and research, has more than 15 years of teaching and research experience. He has more than 22 years of experience in the pharmacy field, and he has completed his pharmacy undergraduation from the Madurai Medical College, Tamil Nadu in 2007. He obtained a post-graduation of M.Pharma in pharmacy practice from Sri Ramakrishna Institute of Pharmaceutical Sciences, Coimbatore, Tamil Nadu. He has completed his PhD in the year of 2013 from the prestigious Tamil Nadu Dr. MGR Medical University, Chennai, and the Good Clinical Practices Licensure exam from the Ministry of Health, Malaysia in 2014. And also, Sir was having experience, he has published more than 75 research papers in various national and international indexed peer-reviewed journals, and has been serving as a chief editor and editorial board member of reputed more than 10 international journals, and has received many grants from the Indian Council of Medical Research, New Delhi, India, and Department of Science and Technology, New Delhi, Center for International Cooperation of Sciences, Chennai, and International Medical University, Kuala Lumpur, Malaysia. And he has presented many research papers in conferences in various countries like Turkey, the United States of America, South Korea, Singapore, Thailand, Indonesia, Philippines, India, and Malaysia. Sir, heartily welcome for today's session, sir. We are going to be eagerly waiting for your presentation. And thank you very much, sir. And I would like to be those who are attending the members is going to be giving the good fruitful for information from the Palaniswamy, sir.
Okay, sir. Thank you, sir. Thank you for the introduction. Can you hear me?
Yeah, sir.
Okay, sir. Thank you. And I'm going to share my slides with you.
Okay.
Please allow me to share the screen. Dear organizers, please allow me to share the screen.
Madam?
So I request Dr. Joshi sir to make him as co-host.
Okay.
Make Palaniswamy sir as co-host.
Yeah, 1 second, I'm doing that.
No problem, sir.
Here you go, Dr. Palaniswamy.
Yeah, okay, sir. So hope you can be able to see my slides.
Yes, sir. We can see you, sir.
Okay. So very good morning to everyone. This is Dr. Palaniswamy Sivanandi from the Department of Pharmacy Practice, School of Pharmacy, IMU. Okay. So I would like to request the audience to please mute yourself. And if you have any comments, actually you can share with me. Okay. And if you're not able to hear my voice, please let me know. Okay. So previously I was planned to talk a topic on essential of nutritions, okay, for the daily living, and to avoid the last minute overlapping of content, just I changed a little bit the title content. Okay. So today we are going to discuss about the overview of drug and nutrient interactions. Okay. And can you tell me about this food? Okay, this is very famous in India, and also in Malaysia, the banana leaf is very, very famous. Okay, so when you talk about food, you know, they used to say, okay, where we can go for banana leaf meals. Okay, do you think this banana leaf meals is a balanced one? There are a lot of rice, you can see vegetables and curd, so many things are there. Do you think it's a vegetable? It is a balanced one. Okay. So if you're not taking any balanced diet, at the end of the day, we have to take the diet with more amount of tablets. Okay. So we must follow some balanced diet. And if you're not following it, what will happen? We have to take too much of tablets. And now the tablet will be the main diet for us. So in order to avoid a lot of complications in the future, whether you have disease or not, okay, but whether you are healthy or not healthy, but you are supposed to take a balanced diet, okay, since young age, then only you can avoid a lot of complications in the future. Okay. So when we talk about health, what we used to say, if I'm asking someone, are you healthy? Okay, they may say, yes, I'm healthy. If you go in depth and ask them, do you have any disease? They may say, no, I don't have any disease. I'm healthy. Actually, what is health? Because we have different understanding about health, okay, and healthy, okay. So when you're talking about health, they say, I don't have any disease, so I'm healthy. If you ask our students, they may say, I'm healthy. I don't have any disease. I don't have any complications. I'm perfectly all right. But health is not only free from disease. So what is health? The health is a state of complete physical, mental, and social well-being. Sometimes we'll be free from disease, but physically will be lack of the physical, maybe the, what is it, attitude, the physical nature or the status of the body. Then sometimes we may have some mental disturbances, maybe anxiety, stress. During the COVID-19 period, lot of changes happen, right? So always we are going every classes online. So fatigue and social well-being. Most of the time we are contacting our family members and everyone through social media, and we don't have any physical contact with them, you know, our friends and relatives, everyone. So the social well-being is interrupted. So if you say literally, we are not healthy, okay, because we don't have all the essential elements. We are not completely physical, mental, social well-being, okay. So it is not only the free from disease. And what is a sustainable health? If we consider this picture, the blue dot is your health, okay. And what is sustainable health? The bigger dot, the saffron color is your sustainability. That is our commitment towards health is known as sustainable health. If you have some commitment, every day you are waking up in the early morning and you're going for walking and you're doing something, your commitment towards maintaining health is known as a sustainable health, okay. And what is wellness? And wellness is nothing but an active process, okay. And if you're aware about making choices, as you are younger, as you are an adult, you have a lot of choices. You can make your choice, whether you have to take a junk food or healthy food, whether you can take a coffee or cool drinks, whether you want to take coffee or maybe the fruit drinks, okay. So the choice is yours. But in case of elderly, the choice is not with them. So whatever you are preparing, you are serving to them, right? So what happened here? The wellness is aware of making choices towards making a sustainable health or successful existence. This wellness coming under 3 tenets, that is consciousness, self-directed and evolving process of achieving super health, okay. And wellness is a multi-dimensional and holistic approach encompassing the lifestyle to make mental, social and spiritual well-being. And again, the wellness is a positive and affirming. If you're not maintaining our health, if you're not having commitment to maintain the health, if you're not following the wellness, what will happen? At the end of the day, we have to take the drug, because we'll be getting more amount of diseases, more number of diseases. There is no other choice. You have to take the drug, okay. We know that none of the drug is safe. All the drugs are having complications. So normally we are taking drug. The drug is nothing but a substance or the substance or a chemical constituents which are used for the diagnosis, treatment and prevention of disease or to modify some physiological function. So when we take drug, what will happen? It may produce side effect. If you are taking 2 or more drug, at the end of the day, we may get interactions. So the drug may interact with another drug, especially when you talk about the topic of the conference. When you talk about the theme of the conference, aging, elderly people, they used to take a lot of drugs. When compared to a normal human being, normal adult or younger, the elderly people are taking more number of drugs. When they take more number of drugs, there is no other choice. They may get more complications. How many of you know how many drugs your parents are receiving or your grandparents are receiving? If you go in depth, ask me a lot of questions, you know, finally we cannot get answer for that, because we are not focusing about our family members, about their health, everything, right? We are pharmacists. We have good qualification, B.Pharm, M.Pharm degree, sometimes PhD holders are there, right? How many times we checked whether the drug is suitable for our parents or not? We can believe the healthcare professionals. I don't say don't believe healthcare professionals. At the same time, we have the responsibility to make the drug more safer, because we are pharmacists. We cannot simply believe everyone, right? So we have analyzing capacity. We should analyze the prescription, right? So what will happen when you're taking more number of drug, the drug may interact with another drug, or it may interact with the food or food supplements. At the end of the day, it may produce either beneficial or non-beneficial interactions. And most importantly, when you're taking too much of drugs, it may produce adverse drug reactions and drug interactions. Till date, even though we are practicing in pharmacy, even last week I was having classes with my postgraduate students. They have a lot of experiences. When I was asking what is adverse drug reactions, almost all, 99%, they used to say, adverse drug reactions are produced by the drug. It is a kind of side effects, okay, and it is unavoidable. You know, still we are thinking that the adverse drug reactions are produced by the drug. It's not like that. The adverse drug reactions and drug interactions are potential threat to life. If we don't have much knowledge about what is ADR and what is drug interactions, then at the end of the day, we cannot save our patients. We can't provide a safer drug to the patient. There are many studies conducted around the world, and the study says that adverse drug reactions are a very big killer. And most importantly, the number of incidents and prevalence of adverse drug reactions and drug interactions are more common among the elderly people. There are many drug interactions, and most of the time when you talk about the knowledge about adverse drug reactions and the drug interactions, it's a pathetic situation. Almost 50% of the healthcare practitioners don't know what is the common adverse drug reactions by the drug. They practice, but they're not ready to recall what are the common adverse reactions produced by the drug, and also what are the common drug interactions. There are thousands of drugs in the market, and every day you can see some drugs are released into the market. Okay, so we are in the position as a pharmacist. In the future, you are going to become a medical representative or maybe a clinical pharmacist, and you will be in a position to educate the doctors and other healthcare professionals about the new drug and its molecules and its drug interactions, adverse drug reactions, everything. So we should have thorough knowledge about the drug. And even when you talk about the neighboring countries, the Pakistan, they say there are 71.8% of the healthcare professionals, they say, I don't know what is adverse drug reactions and I don't know where to report it. I'm giving some example. Okay, there are many studies are there. When you talk about the incidents in US, we know that US is a well-developed country, and United States of America, everything is structured one. They used to treat the patients as per the algorithm. They have a separate algorithm. Okay, they will follow the algorithm. Most of the countries will follow the algorithm. Step 1, step 2, step 3. In that country alone, they say there are 2.2 million Americans suffering from adverse drug reactions every year. Even though they have the protocol, they used to record all the events. But you talk about the underdeveloped countries or developing countries, we don't have any structured one. And in US, there are more people die from adverse drug reactions to the prescriptions as well as OTC medications than illegal drug use. The illegal drug use kills only 5,000 to 10,000 people, Americans per year, but the adverse drug reactions kills almost 2.2 million. They're suffering from 2.2 million Americans are suffering from the ADR. As you know that polypharmacy, because already Dr. Sulvel Raj sir talk about the polypharmacy. When you are taking 2 or more drugs, it is considered as a polypharmacy. Poly means more and pharmacy means drugs. When you are taking 2 or more drugs, no other choice, you will get drug interactions. A study says that if you are taking 4 drugs, there is a chance for 1 potential drug interactions. And if you are taking 8 drugs, and there is a possibility for 3 potential drug interactions. So simply we cannot throw the medicine to the patient to take, right? So you have to think about all the possible drug interactions and adverse drug reactions associated with the drugs. Especially in old age people, the study from US says that there are 15 to 18 prescription medicines are received by the elderly people. They are the guinea pig. They are the guinea pig because all the drugs are dumped in the elderly people and they used to take more number of medications. When compared to adult, early adult or youngers, the elderly people, the senior citizens are taking more number of medications when compared to your normal younger people. At the end of the day, they will end up with a lot of complications. When we take more number of drugs, we will get more complications. Yes, the drug may interact with each other. Not only it may interact with each other, it may interact with the food supplements and whatever you are consuming. It may be a drinks, it may be a alcohol, or it may be a cool drinks, whatever it may be. It can interact with each other. So when you are taking more number of drug, it may produce more complications. At the same time, when you have more complications, you have to take more drug. No other choice. So far, we don't have any single drug to cure all the complications, whatever the elderly people are having. So when they have more complications, you have to go for more number of drugs. So both are interchangeable. Let us say, for example, you are consulting a doctor for your common cold. You have simple common cold, runny nose. Okay, runny nose, common cold, fever, headache. Okay, and you are consulting your doctor to get some medicine for your common cold. How many drugs you can expect? For your fever, they will give one drug, a paracetamol, and for your runny nose, cetirizine. And because you have infection, so an antibiotic. As you are taking 3 drugs, there is a possibility for gastric upset. So one ranitidine or any other proton pump inhibitors. Because you are taking so many drugs, right? One multivitamin. So whether it is necessary or not, you will be having almost 5 drugs, 4 to 5 drugs in your prescription for simple common cold. But we have to understand that the common cold is self-limiting one. Whether you are taking the drug or not, the common cold will be there for 1 week. It is an acute inflammation. The inflammation will be there for 1 week. It is a self-limiting one. You don't need to take any medicines unless you can't able to tolerate it. You can't able to tolerate the symptoms of common cold. So what the study says, one among the 3 drugs are not essential for your conditions. Even I told you in common cold, you don't need to take any medicines. Just wait for 2 days, 3 days. If you can't be able to control, then you can go for medicine. Otherwise, it's a self-limiting one. So like that, most of the drugs, what we are consuming, okay, major percentage are not necessary at the moment. And what is adverse drug reactions? Because our students are having misunderstanding, adverse drug reaction is produced by the drug. So we cannot avoid it. But the problem is, ADR is not produced by the drug. It is the response produced by the body to the drug. Normally, we are giving the drug for the diagnosis, prophylaxis, or the treatment of your disease, or to modify some physiological function. Even though you are giving a normal dose, the drug may produce the response to the body, but the body will not accept that response, whatever the drug produced. So it may create another response. That response will be unintended or noxious. Okay, so ADR is a response by a body to the drug which is noxious or unintended, even though you are taking at a normal dose of the drug. So you have to understand that concept. You can give the same drug to any kind of patients, but if the patient body is not accepting, then the patient developed with ADR. So there are different types of ADRs are there. Type A to type U. I'm not going to talk about all the different types now. Okay. And what is drug interactions? When you are taking 2 or more drugs, the drug may interact with each other, especially elderly patient. They are more susceptible to have drug interactions. When you are giving too much of drugs, the patient will get drug interaction. Not only the drug may interact with the food. The drug may interact with the food. The drug can interact with the supplements. And nowadays, the drug can interact with the medical conditions. So at the end of the interactions, we may get either beneficial or non-beneficial. Either it may decrease action or increase action, or it may produce side effect. We can classify the drug interactions in different category. Either it's a drug-drug interactions or drug-food interactions, and whether it's clinically relevant or not. When you are sitting for the pharmacology exam, normally we have some experience, right? When you're sitting for pathophysiology exam, pharmacology exam, when the examiner asks, can you give me the side effect of the particular drug? If you know the answer, we used to say, okay, this is the side effect peculiar or the selective side effect for the particular drug. Otherwise, we used to say nausea and vomiting. Everyone experienced in our Viva, because we come across undergraduation, post-graduation, everything, right? If you know, if you don't know the answer, we used to say, okay, nausea and vomiting. The examiner also cannot say no, because almost all the drugs produces nausea and vomiting. But it's not clinically relevant. If you have repeated nausea and vomiting, uncontrollable nausea and vomiting, then it is clinically relevant. For example, the nausea and vomiting induced by anti-cancer drug. So based on the reaction produced, we can classify either clinically relevant or not relevant, based on the benefit, based on the reactions. Sometimes it may produce either beneficial or adverse reactions. You are taking paracetamol and you're not getting complete cure from your headache or body pain. Again, you are taking another one drug, maybe ibuprofen or aspirin. Again, you can get better recovery. You can get complete recovery from the body pain or fever. But at the same time, it's a beneficial effect because you can get recovery from the body pain as well as fever. But at the same time, it may produce gastric erosion. So adverse complication. Based on action, we can classify the drug interactions into either pharmacokinetic or pharmacodynamic. Pharmacokinetic, that is, one drug alter the absorption, distribution, metabolism, and excretion of another drug, ADME. When you talk about the elderly people will be having down regulation of ADME, absorption, distribution, metabolism, and excretion. At the time when you are giving drug, it may produce serious complication to them. So we have to titrate the dose according to the age, according to the body mass, according to the clinical conditions, comorbidity. So the drug interaction can be classified into pharmacokinetic as well as pharmacodynamic. Based on the severity, we can classify either mild, moderate, or severe. And based on the effect, we can classify either synergistic or antagonistic effect. Okay. What is food-drug interactions? Not only the drug may also interact with the food. The drug may also interact with the alcohol or food substance or maybe supplements. So when you are taking the drug along with the food may interact with food and drug, it may interact with each other. At the end of the day, it may alter the absorption, distribution, and metabolism or the pharmacological action of the drug or the food. The drug-nutrient interactions. We can classify the food-drug interaction into two, drug-nutrient interactions or food-drug interactions. So when we are having drug-nutrient interactions, it may put changes to your drug. The nutrient may interact with the drug and it may produce changes to the drug. Or the nutrient may produce changes to the drug, or the drug may produce changes to the nutrient. Interchangeably, they can produce some interactions. When you talk about food and drug interactions, food is a collective terminology, umbrella term. So the drug or the nutrient can interact each other. At the end of the day, the absorption, distribution, metabolism of everything will be interrupted. We know that the metabolism of drug, when we are taking any drug, the drug will go to dispersion, dissolution, then absorption. After the absorption, the drug go to displacement and will bind with the receptor. And from the receptor, whenever necessary, the drug will be released to the systemic circulation and it may produce action. Then it go to metabolism. After that, the drug will be eliminated through the excretory organs. So the interaction can happen in any area, either starting from the dispersion to elimination. The interaction can happen any area. That's why you have to be very, very cautious when you're giving drug to your patient, especially elderly patient. So coming to the effect of food on drug intake. So when you're taking food, some food can interact with the drug. At the end of the day, it may interrupt the absorption of the food, or it may interrupt the absorption of the drug. So the effect of food on the drug intake. It can reduce absorption of the drug. Once the drug is not absorbed, they cannot produce enough amount of action to the patient and break down. The drug may inhibit the metabolism of the drug. Either it may inhibit or increase the metabolism. I will give you some example in my future slides how the drug inhibits or the food inhibits or increases the metabolism of the drug. And excretion. The food and the nutrient can interact with the excretion of drug. If the excretion is inhibited, the toxic level will be more in the body and it may produce complications. So at the end of the day, the drug and food interactions may produce enhancement or opposition of effect of the drug. Coming to the effect of drug on food and nutrition. There are certain drugs, the drugs can inhibit the absorption of nutrients. Let us say, for example, methotrexate can inhibit the folic acid. Okay, so the drug act on the absorption of nutrients, so the nutrient will be either inhibited or absorbed more. Even though it is a nutrient, if the concentration is more, it will be a toxic one. Again, the drug may interrupt the breakdown of the nutrients. At the end of the day, the drug will be inhibited, or maybe the metabolism will be promoted or inhibited. At the time, they will not get enough amount of drug in the body to produce action. And the drug also can inhibit the excretion of the nutrient as well. Coming to the side effect of the drugs and other medications. So what will happen at the end of the day, we may have drug and nutrient interactions, or drug and drug and food interactions. So when the drug affects on the food, what will happen? It may alter the taste and smell. So normally we are consuming good quality food and also more amount of food because of the taste. If you do not have the taste, if you can't understand the taste and smell of the product, will you consume it? No. Especially in old age people, they want tasty food, right? If something is not tasty, they will not take it. They will not adjust. We can see in our family, they may be 60 years, 70 years old. The below 60 can adjust the taste. Okay, so no problem. They can adjust and go. But if it goes to above 60, they're peculiar. They want the taste. If you're changing the taste, they will not accept. So they're more keen towards the taste and smell. So now some of the drugs can alter the taste and smell of the food. At the end of the day, they will not consume more amount of food and it may end up with malnutrition. And again, another thing, gastrointestinal effects. The drug may produce some gastric erosion or maybe inhibit the absorption of nutrient from the gastric system. This may lead to lack of nutrient in the body. Again, some of the drugs can affect the appetite. You can see after taking the antibiotic, I'm not getting good appetite. After taking the particular food, I'm not getting good appetite. So the drug may alter the appetite. So this may lead to lack of food intake, especially in the new elderly people, it will be there. And organ toxicity. None of the drug is safer. So when you are taking too much of drug, what will happen? The drug may affect the system, especially the main organs like liver, kidney. Almost all the drugs, 90% of the drugs are metabolized through the renal system. So it may cause the liver toxicity and renal toxicity. And metabolic effects. The drugs can cause effect on the metabolism. It may lead to metabolic complications. Okay. Apart from all the complications, the drug also can produce economic burden to the patient. Most of the time, the doctors not the patient, most of the time the patients or the patient's attendant and all the people, they're not explaining the economic burden to the doctors. There are different products available for the different prices. The same product available in cheaper prices, the same product available in costly prices as well. So we have to inform the doctor, I'm having financial burden. Most of the time, along with these complications, when you're taking too much of drugs, it may produce economic burden. And after taking too much of drug, you may end up with adverse drug reactions or complications, drug interactions. So we cannot simply leave the patient or discharge a patient with adverse reactions or complications, right? So at that time, we have to treat the patient with additional treatments, or it may increase the hospital stay. So it is another reason for the economic burden to the patient. And who is at higher risk for drug and nutrient interactions? Those who are taking poor diet, those are having serious health issues, children, pregnant women, and most importantly, the older adults, the elderly people, and those are taking 2 or more medications, and those people taking prescription product or OTC products. Okay, and they are having more chance to get drug and nutrient interactions. Coming to some of the example here, the drug and nutrient interactions, the methotrexate. So when you're taking methotrexate, it may interact with the folic acid. So it may inhibit the folic acid absorption. I will give you another one example here. That's a furosemide. We know that furosemide is a laxative. It's a diuretic. Furosemide is a diuretic. It's a loop diuretic, and it may act on the loop of Henle, and it may produce hypokalemia and hyponatremia. So when you are giving this drug to a hypokalemia patient, again, the patient may get severe complications. Another example, statins, atorvastatin. We know that atorvastatin is a very good drug for cholesterol, dyslipidemia. At the same time, the atorvastatin may produce rhabdomyolysis, the breakdown of muscle fibers. When you are taking atorvastatin along with the grapefruit juice, it may cause inhibition of the statin metabolism, and at the end of the day, due to excessive concentration in the body, the patient may get excessive rhabdomyolysis. And another one, drug, steroids. We know that the corticosteroids can produce hyperglycemia. If you are giving corticosteroids to a patient with diabetes, it can produce hyperglycemia. At the end of the day, the patient will get excessive glucose, and you have to boost up the dose. Okay. Coming to the effect of drug on the nutrient absorption and its metabolism, there are some of the drugs like cimetidine and ranitidine. The concentration of the drug will be, the absorption of this drug will be increased when you're taking along with the nutrient. That is, the cimetidine and ranitidine. Okay, when you are taking this cimetidine and ranitidine along with the food, the absorption of this drug will be maximum. And the decreased nutrient absorption, when I see example, colchicine, alcohol laxatives, and some antibiotics like neomycin, it may decrease absorption of nutrient. So when you're taking this drug and when you're giving this drug to a patient, elderly patients, the absorption of nutrient will be very, very less. Already they are not taking adequate quantity of food. At the end of the day, they may get lack of nutrient. And diuretics and chelating agents, alcohol can also interrupt the mineral absorption in the body. This may lead to mineral depletion. And vitamin antagonist and contraceptives. Okay, so when you are taking contraceptives or vitamin antagonist along with the vitamin absorption will be very, very less in your body. This may lead to vitamin depletion. Coming to another example, as I told you, the grapefruit, we know that what is grapes, but most of us, we don't know what is grapefruit, right? Grapefruit is different from grapes. So when you are taking grapefruit, the grapefruits having a chemical substance known as psoralen. The psoralen is a potential inhibitor of cytochrome P3A4 isoform. We know that almost 90% of drugs are metabolized by oxidation and especially by cytochrome P450, cytochrome P450 enzyme groups, right? So here, when you're taking grapefruit, it contains a chemical substance psoralen. It may inhibit a cytochrome P3A4, and most of the drugs, what I mentioned here, that is carbamazepine, buspirone, and calcium channel blockers, all are metabolized by these enzymes. When the enzyme is inhibited, what will happen? The concentration of drug will be more in the body. At that time, the patient may get excessive concentration. For example, atorvastatin. When you're taking atorvastatin with the grapefruit juice, the concentration will be maximum in the body. This may lead to severe rhabdomyolysis, muscle breakdown, and the patient will get severe muscle problem, and they cannot jittery movement, everything will be there, you know. Okay, so coming to another example, patients taking warfarin with the food rich in vitamin K. The alfalfa tablets, broccoli, cauliflower, and green leafy vegetables are very rich in vitamin K. We know that warfarin is an anticoagulant and vitamin K is a coagulant. You are not taking vitamin K as such, but you are taking warfarin along with food substance like alfalfa tablets or broccoli. What will happen now? The warfarin can interact with the vitamin K. At the end of the day, the patient will not get the therapeutic benefit. And another example, drug and food interactions. The absorption of tetracycline and ampicillin is reduced by food. because the absorption of tetracycline and ampicillin, they need acidic medium of the stomach for the absorption. When you're taking along with the food can reduce absorption of tetracycline and ampicillin. At the same time, the absorption of grisofulvin is maximum when you're taking along with the fatty foods. This is an example for how the drug interact with the food. And again, drugs and herbal interactions. When you talk about in Malaysia, wherever you go in community pharmacy, you can see almost 80 to 90% of the herbal supplements. The drug will be there in only one area. The drug will be there in only one cupboard. But almost 90% of the pharmacy will be occupied or dumped with the supplements, the cosmetics and supplements. So not only in Malaysia, even in India, nowadays, most of the people used to take the drug herbs. Especially we are used to give the herbs as a supplement. What will happen when you are taking any herbs along with the drug, it may interact with each other and it may produce complications. Let us say for example, alprazolam. So when you are taking alprazolam along with the kava lactone present in the kava may interact with alprazolam and it may increase the CNS activity of alprazolam. Now the patient may get excessive sedation. When you are taking amoxicillin along with the cathinone present in the amoxicillin can interact, and at the end of the day, it may produce delay or decrease the absorption of amoxicillin. The patient cannot get the effect of this antibiotic. And we know that digoxin, warfarin, all are coming under narrow therapeutic index class drug. If you are taking a little bit less, it cannot produce a therapeutic action. If you are taking a little bit more, it may produce toxicity because the lethal dose and effective dose both are in very marginal level. So if you are taking a little bit more, it can produce toxicity, and if you are taking a little bit less, it cannot produce the therapeutic benefit. So when you are taking digoxin along with the ginseng, the gintonin present in the ginseng can interact with the digoxin, and it can elevate the serum digoxin concentration by 75%. When you are taking digoxin with the St. John's wort, the flavolactone present in the St. John's wort interact with the digoxin, and it can decrease the serum concentration of digoxin by 25%. So it cannot produce a therapeutic benefit. But when you are taking it with the ginseng, it increases the concentration by 75%. Now the patient will get severe digoxin toxicity. Again, another one example, warfarin with the licorice. The lactones present in the licorice interact with the warfarin, and it increases anticoagulant activity of warfarin. Thereby, the patient will get severe bleeding complications. Another example, drug and disease interactions. When you are giving any gentamicin or any aminoglycoside antibiotics, we know that these aminoglycoside antibiotics can produce ototoxicity, nephrotoxicity, and neurotoxicity. When you are giving these type of drugs to a patient with renal failure, already the patients have a renal failure, and these drugs also can cause excessive complications, and at the end of the day, the patient will get severe renal failure. Okay, so this is some of the example for you. So how to find out the drug interactions? Where you can get all these informations? There are a lot of drug interaction checkers are there in the online. You can use these online checkers to find out the drug interactions. Okay, you can go through, maybe you can go to drugs.com website. In the drugs.com website, just click accept terms and conditions. You feed all the drugs, you feed all the supplements, whatever you are consuming. It will analyze the case and it will give you the clear data whether your prescription is having drug interactions or not. Okay, so no need to try the test now due to lack of time. Okay, so who can monitor drug interactions? Anyone can monitor, either you, me, or anyone, the healthcare team members, even the patient attendant, and the caregivers. Anyone can monitor and report ADR as well as drug interactions. Okay. And there are some drugs are contraindicated to a special group of people. For example, some drugs are contraindicated in pregnancy, and some drugs can produce drowsiness while driving. So you have to provide appropriate precautions to them. And another drug should be taken along with alcohol. Okay. And some drugs may cause photosensitivity reactions. So when you are giving these type of drugs as a pharmacist, you must explain the patient these drugs can cause these complications. Even if you see, if you go to Malaysia, even in the pharmacy, they will dispense a product. At the same time, along with the dispensing the product, they will say if you're taking this medicine, you can experience this side effect. Okay, they will give the appropriate advice. But if you go to our pharmacy, in India, if you ask some medicine, they will give, okay, paracetamol 10 tablet. If you want atenolol, they will give 10 tablet. Whatever you want, you can buy. But they will not provide any advices. They will not give any appropriate informations. When you're taking this drug, you can experience, you may experience, you may or may not experience these complications or side effects. We have to explain them. But we are not doing our duty because most of our pharmacy are occupied by the non-pharmacists. Because our pharmacies are giving our certificate for rental purpose and we are getting 1,000 rupees or 2,000 rupees, and the people working in the pharmacy are non-pharmacists and they're selling their product. They're thinking it's a business. The non-pharmacists, for them, it is a business. Actually, pharmacy is not a business. It is a healthcare service. Okay, you have to think in that way. Okay, so just understand yourself, ask these questions to yourself. How many drugs are your parents or grandparents consuming per day? Do you have the answer? Just check your knowledge. Do you know or not? Do you know the name and dosage of the drugs that they receive? Then, did you check their medications and its possible interactions? Most of us know that our parents are receiving some medications, but we don't know what type of medicine they are receiving. Maybe you can say anti-diabetic medications, maybe anti-hypertensive medications, but we don't know what is the name, what is the dose, what is the formulation. Did you check any interactions or any drug-related problems in the prescription? Did you ask them how the medicine works or got any side effects or any symptoms after consuming it? Even though we are pharmacists, we have the qualification, we are in the healthcare team, but we are not doing our duty even to our parents and family members. Then how we are going to take care of the general population in future? Right? So most of the time we are not asking. If you ask these questions, we may say, why? No answer from our side, right? Because we are not doing our duty properly. So finally, what will happen? They may get a lot of complication, drug interactions or some other complications. Then we have to take them again back to the doctor's clinic for getting additional treatment, economic burden. Coming to the take-home message, there are many types of complex drug nutrient interactions as well as food drug interactions, and these type of interactions are more common among the elderly people. Okay, so you have to be very, very careful when dispensing the product or when you are advising them to take the medicine. Because most of the drug and medications can cause changes in the taste, appetite, as well as digestion and metabolism. Okay, so sometimes we can see whenever the elderly people not taking food, appropriate quantity of food, after receiving an infection or after getting some infection or disorder, or maybe after receiving a medicines, we have to ask them whether really they don't have appetite or because of the drug inducing lack of appetite. We may think that he's having infection, she's having infection or illness, so father, the mother is or father is taking the medicine. Due to the health illness, they are not taking adequate quantity of food. Sometimes the drug also can cause lack of appetite or maybe some indigestion to them. So that's why they do not take more amount of food. If they're not taking adequate quantity of food, they may get lack of nutrient. At the end of the day, they may lose their quality of life. And always consult a physician or pharmacist before taking any medications. And please make sure that the self-medication may cause lethal effects in elderly. So advise them, don't go for any self-medications. And check with the doctor or pharmacist for the appropriate method of administration as well as time to take the medications. And always, if you're not sure with anything, even though you're a pharmacist, we can't say 100% we are perfect, right? So if you're not sure, you can discuss with your colleague or peers or maybe supervisors. And if you don't know anything, just refer the patient to your physician for any health issues and for getting appropriate advices. Okay. Please always remember the patient safety is first. The business is next. Okay. Thank you. you have any query?
I think there is a question from Dr. Jnanachandran sir. His question is, please share opinion about FDC of 2 antibiotics with lactobacillus.
Okay. Normally what will happen, when you're taking antibiotics, normally the antibiotics will cause serious health issues to the elderly people, but most of the time we are supposed to give the lower dose, and as it is a fixed combination, and you cannot break the tablet because the tablet will be having coating and everything. And normally we are giving the formulation what they marketed to the marketed in the market, the fixed dose formulation we are giving, but actually it's not sufficient, not suitable for the patient. Those are elderly. So you have to titrate the dose, and most of the time we are not breaking it.
5 minutes.
Okay. So you have to titrate the dose according to the patient need, especially elderly people. We have to go for the appropriate dose of antibiotic instead of giving a common dose what we are giving for elderly people. Okay, and especially many antibiotics are there, it can cause gastrointestinal upset. And due to the gastrointestinal upsets, they will not take proper food, and at the end of the day, they may get complications.
Yeah, thank you. Thank you so much, sir. I request Dr. Vagesh to take over this session.
Sir, thank you very much, sir. Sir. It is very good, informative for all our viewers, and also I had to come to know that what is the importance of health and what is the importance of nutrition, and also you can come to know the drug interactions. Very fruitful session, sir. I'm very thankful to you. And future, requesting you to be and conduct if anything we need to your blessings, and also need your shares, views of the things. And thank you for our Joshi sir and the entire organizing team and treasury, all the members. Thank you, and giving an opportunity to chairperson for this session. Thank you, sir.
Thank you, everyone. Thank you to the organizing committee of APSC.
Madam.
You're muted, ma'am.
I request Dr. Neetu, sorry, the technical glitches from my side. I request Dr. Neetu to share the certificate slide, and I request Dr. Sharda Diole to share this, hand over the certificate of appreciation from on behalf of our APSC to our speaker of today. Dr. Sharda?
Yes, madam. Yes, thank you
Dr.
so much. Yes, am I audible, madam?
Yes, yeah.
Yes. Thank you so much, Palansi Swami sir. It was really very nice session, and here with the token of love, we are proudly presenting this certificate to you. It is the part of our syllabus also, as per new PCI guidelines, and it is really a thought-provoking session, so that we teachers also can contribute your thoughts, your expressions while our teaching, and also will take part as research also. Thank you so much, sir.
Thank you.
I request Dr. Neetu to share this certificate screen, please. Dr. Neetu? Yeah. Anyway, I can understand there is a technical glitches from everyone's side. I can understand. Yeah. So on behalf of APSC, I convey my sincere thanks to Dr. Palaniswamy sir to share his valuable time and his ideas with the delegates. And really, thank you so much, sir. Future Day's contribution as well as the collaboration. We are looking forward from your side, and the due course of time, we'll send you your certificate to your email. And thank you once again from APSC for your valuable time to share with us. Thank you, Dr. Palaniswamy. And now I request Dr. Neetu to take over the presentation part. Dr. Neetu.
So, good afternoon, and all. Now I call Dr. Jinesh Nakavi to introduce our speaker, Sharada, ma'am. Dr. Jinesh Nakavi has completed a PhD from Department of Pharmaceutical Chemistry, JSS College of Pharmacy, JSS University, Mysore from 2013 to 2017 on the topic of bioanalytical method development for the simultaneous determination of drug acting on cytochrome P450 enzyme drug interaction study. He has completed his B.Pharm and M.Pharm from Rajiv Gandhi University and Health Science Bangalore, Karnataka. He has worked as an executive in Department of Quality Assurance, Neo Pharma, Abu Dhabi, in the year of 2010. And also he has worked as an instructor and lecturer at RAK College of Pharmaceutical Science, RAK Medical and Health Science University, UAE from 2010 to June 2013. And Dr. Nakavi has about 8 years of experience in teaching and research of pharmacy and health sciences. And he has presented research work in DUFAT from 2010 to 2013 as both poster and oral presenter. And also has presented research in both oral and PCON in USA in March 2013. And he has published 10 research and review papers in national and international peer-reviewed and high-impact journals. His area of interest as quality control and quality assurance and academic and research activities, bioanalytical methods and development, and validation stability indicating method of analysis. Now I request Dr. Nakavi sir to introduce our speaker. Thank you.
Good afternoon, everyone. Thanks, Dr. Neetu, for this nice introduction of mine. Am I audible? Hello?
Yes, sir, you are audible.
Yeah. It's my immense pleasure to introduce our next speaker, Dr. Sharada Diore. She's basically working as an associate professor at Government College of Pharmacy in Amravati. She has completed her M.Pharm and PhD in pharmacognosy and phytochemistry. She has immense experience in teaching and research. She has published more than 50 research and review articles in national and international peer-reviewed journals. She has also written and authored some books in pharmacognosy and phytochemistry. I was just having a look at the Google Scholar of her citations and all. She has more than 1,500 citations in Google Scholar, and she has around 37 as I-index. So I welcome Dr. Sharada Diore to start the session of in this International Conference of Healthy Aging and Research. Welcome to you, ma'am, for this conference. We are eagerly waiting for your presentation. Your audio is muted, ma'am.
Yes. Am I audible, sir?
Yeah, please.
Thank you so much, Nagavi, sir, for this brief introduction. I'm thankful to Muthuraman, sir, then APSC, Milind Palre, sir, and team, ICMR, Honorable Subarna Roy and team, then Sharda Vilas College and the Joshi sir and team, Deepa ma'am and all, for this opportunity, for giving me this opportunity to present my research work which is based on the RGSTC, Rajiv Gandhi Science and Technology Mumbai funded project, and as well as some part is funded by the Department of Science and Technology, DST, Delhi. So I have to share my screen, Madam Deepa ma'am. Joshi sir, I'm unable to share my screen.
I request Dr. Joshi sir to make ma'am as a host for the session. Hello, sir.
It is displaying that host displayed participant screen share.
Wait a second, ma'am.
Yes.
Now you are the co-host, madam.
Okay, sir. Thank you, sir. Thank you, sir. I think I have to rejoin, sir, again.
Sorry, ma'am. Some technical issues, ma'am. We'll sort it out. Sorry for making delay. Ma'am, now you are the co-host, ma'am. You can share your slide. Hello, ma'am. Hello, ma'am. Hello, ma'am. Can you hear me?
Am I audible, madam?
Yes, ma'am.
Am I audible, madam?
Yes, ma'am. We can hear you, ma'am.
So here with I'm sharing my presentation. Is slide visible?
Yes, ma'am. It's visible.
So today I'm going to present my perspective as a part of the research of these two DST and RGSTC sponsored project with Vidanferin A versus Vidanolides, that is neuroprotective as well as medical aspects. So while doing the work on this particular, we come to know that there is a lot of research which is available on this plant Vidania somnifera, and it is having the different type of the constituents that we can see here. that is the vidanolide lactones or alkaloids or saponins, the lactones which are attached with some glucose, and various types of the steroidal or flavonoid compounds, and all together are responsible for number of activities. Means if you will go through the research, there are lakhs of paper, and each and every research is trying to discuss the different aspects of this Vidania somnifera, which is also known as the Asian ginseng, which are the various traditional properties as well as the biological properties that we can able to go through the details of this research paper. And most important properties which are mentioned in the Ayurveda, Siddha or Unani system, that are anxiolytic, antidepressant, antimicrobial, and then nowadays with modern aspects, that is antimalarial, chondroprotective, cardioprotective, immunomodulatory, and neuroprotective. There are different aspects which are mentioned about the Vidania somnifera in various traditional systems. And when together we have gone through these details, it is always means as a being teacher, as a being academician, being in various research activities of MPharm and PhD students, we always think that suppose atropine, this scopolamine and scopoline, these are structurally very similar. Still, their activities are different, their uses, their commercial market is different, indications are different. Each and everyone is having very different type of the drug related indications or side effects or note to be taken into care. Each and every has the different aspects. So this for this particular Vidania or Ashwagandha, from the traditional perspective point and from the modern perspective point, we have seen that in a neurodegeneration, especially in case with the Alzheimer's disease, it is found that neuroinflammation plays the role, which may be due to the oxidative stress throughout the aging, which we come across. Then mitochondrial dysfunction, there can be the brain injury or neuroreceptor malfunction, and the most important, along with the neuroinflammation, it is the beta amyloid plaque deposition. So that these factors taken into together with environmental and genetic reasons, how the plant materials, how the different traditional medicines can play role in such a modern disease condition, that is of Alzheimer's, because Alzheimer's disease is nowhere mentioned in Ayurveda, Siddha or Unani system or in any traditional system. There is only the neurodegeneration like that, or Medhya rasayanas are there, so that can be helpful for the healthy brain. It was nowhere it is mentioned about the Alzheimer's disease, but taking into consideration of the burden of Alzheimer's disease throughout the world and its medical cost, especially the care cost that one cannot afford, for that purpose we have taken into the consideration of this particular project. And while searching on this, we have found through the various literatures that Vidania somnifera is very good neuroprotective herb, and it has been reported why it is neuroprotective. There are the two major ingredients, chemical constituents, which are found to be responsible for this neuroprotection. One is the vidanferine and another are the vidanolides. There are different literatures which are claiming different vidanolides. Some are telling vidanolide A is responsible, some are telling that vidanolide D is responsible, others are saying that vidanolide S are responsible. So altogether, as per my knowledge and as per my phytochemistry research, I can say that all vidanolides can play a role. So vidanferine A, which is having the effect on the amyloid induced neurotoxicity, because all we know that this beta amyloid, which are means this is the peptide of 36 to 43 amino acids, which triggers these accumulations of the neurofibrillary triangles, and hence there is loss of signal processing. Is my next slide visible to all of you?
No, ma'am. It is here.
Madam, please make it full screen.
Yes, it is full screen, sir. Okay, sir. I'm stopping it and then starting it again. Now is it visible, sir?
Okay, ma'am. Yeah, please continue, ma'am.
Yes, I have just discussed about these all chemical compounds and the role of neurodegeneration in Alzheimer's disease and factors responsible for this Alzheimer's disease, whatever the traditional claims of Vidania and modern claims of Vidania. Now, the role of Vidania somnifera in neuroprotection, especially with reference to the vidanfarin A and vidanones or other vidanolides. So, obviously, they are doing they are working on the beta amyloid plaque formation or this other acetylcholinesterase or glutathiones or these type of the enzymes which are playing the role in the neuro signaling processes or secretase enzyme, then deposition of the various proteins along with the beta amyloid which are responsible for the inflammations, and various antioxidant perspective responsible chemicals also, or the enzymes which are responsible for this antioxidant activity, which can able to play the important role in the beta amyloid formation or inflammation. Then we have searched a thorough literature, and we have come to know that vidanfarin A, vidanone, and vidanolide have some chemical differences. It is same like that of atropine, hyoscyamine, and hyoscine, where we can see that the double bond at C23 and epoxide at 5-6. You can able to see that. Is this structure slide visible to all of you? Is this slide visible to all of you?
Yes, ma'am.
Vidanfarin A, which is having the epoxide at C5-6 position, while vidanone is having at different position. And again for the vidanolide, means there is lactone ring present that we can accept, which is very similar to in these three chemicals. But while differentiating between the vidanfarin A and vidanolide, there are so many researchers that are come with this particular knowledge that vidanfarin is non-selective between the normal cells and cancer cells. So if it is non-selective, then it is cytotoxic. Vidanfarin A is cytotoxic, and that is surely going to play the important role when we are taking into consideration about its nutraceutical aspects in neuroprotection. Means whenever we are considering ashwagandha for cancer treatment, vidanfarin A is very good candidate. Is this slide visible to all of you, where I'm trying to show my research work?
Yes, ma'am.
So here we've taken into this consideration, we have prepared the bioactive rich fractions 2 extracts, where we have minimized the vidanfarin A concentration, and in another fraction we have tried to have the more vidanfarin, means in one less vidanfarin and more vidanfarin. 2 fractions are prepared. That is with the combinations of the various extracts, with the knowledge of the phytochemistry, N-butanol, ethyl acetate, ethanol, methanol. These 4-5 solvents are taken into consideration while preparing these bioactive rich fractions. For these 2 extracts, I have also applied for the patent, and I'm sure that it will be get granted. And we have done all the phytochemical evaluations so that we should get confirmed that extract should be as per the objectives, that less vidanfarin A content or without vidanfarin A, and one with the more vidanfarin A content. And then we have performed toxicity studies, where we come to know that yes, when the extract which is having the more vidanfarin A content is toxic to the rats. It is toxic to the rats, and in a nutraceutical dosage form, especially it is toxic to the lungs also. It is found toxic to the lungs. It is having the cytotoxic effect, means the marketed extract like the Subsina or this here you can see that KSM66, which is and collaborated company where you, which is more popular ashwagandha extracts with a negligible quantity of vidanfarin A. And in case of Alzheimer's disease, which may start from the age of 55 or 66, we can give this particular Vidania somnifera standardized extract as a part of a nutraceutical supplements for the healthy brain, for decline in the deposition of the beta amyloid, or for the proper signaling, proper antioxidants and proper acetylcholinesterase inhibitor activity. That time it is very necessary that we should come into, we should give attention to the vidanfarin A concentration in this extract. So there are so many plants which are in market, and without the much attention to its phytochemistry, but without much attention to what Ayurveda Siddha Unani system is saying about processing of these drugs and in what form that should be get used, it is always neglected by the modern scientists. And it is appeal from this presentation that each and everyone should give attention that exactly what traditional medicines are trying to say is that in which form that should be used, in which conditions. For every conditions, the Vidania is processed in different forms and should be used in different, like that. It's processed with dugdha, because milk in Ayurvedic era there was no methanol or there was no benzene, petroleum like solvent use is preferred. Instead of that, go mutra or go dugdha, that is cow milk, cow urine, this type of solvents used by these Ayurvedic physicians or Vaidu and Hakims or this particular Vaidhyars, so that they can implement these chemical constituents useful for that particular disease which is complained by the patient. And in this way, with this presentation, I am concluding that Vidania somnifera fractions, root fractions with the less vidanfarin A content should be used for the neuroprotection purpose. It is not, I'm not claiming that for cancer vidanfarin A content should be less, but whenever there is a role of a nutraceutical, normal cells are there, we are taking it for long time, and hence vidanfarin A concentration should be taken into consideration. So I'm thankful to the organizers for giving me opportunity. If there is any question, you can ask.
Thank you, ma'am, for your valuable information and time given with us. Now it's open for the question and answer session. Delegates, if you have any question, you can put in your chat box.
I think that there is no question.
Yeah, ma'am. There's no question.
So, yes,
ma'am. Thank you so much, ma'am, for your time. And now I request Dr. Jinesh Nakavi, sir, to hand over the certificate to the presenter. Jinesh, sir?
Thank you so much, madam. It was a very nice and short and sweet presentation. We really got valuable information regarding vidanfarin and other nutraceuticals, and how this drug is more beneficial to the Alzheimer's and dementia patients. I could see some of the chromatograms and HPLC data which has been taken from your study. We are very thankful for your presentation. It was a very nice and informative. Even though we don't have much questions from the audience side, I have one small question to ask, that how this vidanfarin and your vithanolide, which we have done the study, is directly related to Alzheimer's and dementia patients. I just wanted to know that how can we directly relate it And what type of studies you have done basically for that?
Yes, sir. Sir, actually the part of the, I have just presented the part of research. The other part which we have just completed, under that we have done some memory, behavioral studies, and some in vitro studies with the acetylcholinesterase enzyme and glutathione dismutase enzymes for antioxidant, anti-inflammatory properties, monoxide aminase properties, and we have evaluated these two bioactive rich fractions for their efficacy in inhibiting these particular enzymes, role in the antioxidant, role in the inflammation, role.
Okay, thank you so much, madam. Thanks for that information. We are very pleased and happy to have you here for this conference. And we are very thankful to present you the poster for, the certificate for your participation as a speaker. Thank you so much.
Thank you, ma'am.
Over to Dr. Neetu.
Thank you, sir. So now we'll start with our poster presentation after 2:30. It's a lunch break. Now it's a lunch break. So I request all the presenters to be ready.
Responsible that are special.
Now I request all the presenters to be ready by 2:30. We have already shared the presentation slot, how we have to present. And I request all the presenters to present your own slide, share your own slide during the presentation. So thank you all. Now we'll resume our presentation by 2:30 p.m. Thank you all.